Good morning, everyone. I am Donna Pickett, as some of you know. We're going to be starting in about 5 minutes. We still have some presenters that have not made it to the auditorium yet, so we want to hold off to give them time to actually get here, and then we'll start. So thank you for your patience. More people joining us, getting set up in their seats, so now that they're comfortable. Okay, we're now going to open the second day of the ICD-10 Coordination and Maintenance Committee. Thank you for joining us today. Our focus today will be the ICD-10 CM diagnosis codes. A few housekeeping pieces of information and some additional things that we have a phone number change for this morning. For people that are trying to dial in and not meeting with much success, there is a different phone number, and that phone number is 415-527-5035. And the ID event number is the same, and that is 909-444-644. We understand that there were some problems yesterday, so hopefully people now will be able to join us with a little more ease than they were able to join us yesterday. So for those of you that have the timeline, which starts on page 4 of the handouts, all of the proposals being presented today are for consideration for October 1, 2019 implementation. We have no expedited proposals for April 1. Now, there are some changes, as noted yesterday during the CMS opening remarks. We do have some changes in terms of deadlines that are of import. One is that we will now be requesting proposals for new codes to come to us in December as opposed to January, which was the case previously. So we're asking for new proposals 3 months in advance of a meeting. So the due date for proposals for the March meeting is December 7. So after you enjoy your Thanksgiving break, you then get to come back and put all your proposals together. Also, as a reminder, for the proposals being presented at today's meeting for consideration for October 1, 2019, your deadline for comments is November 13th. And a reminder, November 13th is a hard fast because we have CMS and CDC have quite a bit of work to do to start to pull together the addenda for October 1, 2019. So getting your comments in quickly, particularly if we have differing perspectives on the same topic, which is turning out to be not quite so unusual as it used to be. Now we're finding we have 5, 6 different perspectives on one particular topic. Excuse me. Also of note, some of you, excuse me, some of you had signed up for our listserv previously. We have migrated to a new listserv, and it is called Gov Delivery. It's not the name that you need to be concerned about, but for each page for which you want to be alerted that there is new information posted, there is on the page, I believe it's on the right, no, it's on the left side, lower left of the page. You'll see where you can insert your email address to request updates, and you'll need to do that for each page of interest. So if you put the request in at our main page, you'll only get alerts related to anything newly posted on that main page. But if you're specifically looking to be alerted to anything related to the CNM process, you'll need to go directly to that page and input your information there. And again, the old system did not transfer over, so even though you may have registered previously through the old system, none of that has transferred over into the new system. Today we have a very full agenda. We have approximately 20 proposals to be discussed today between the morning and the afternoon. We are going to be kind of moving around in terms of the presentations as we await presenters to arrive, but also with our new WebEx system, we want to make sure that we're giving ample time for people to actually able to dial in. As was noted yesterday, this is a new system, so not only is it new to the people trying to dial in, but it's new to us on the side that's trying to manage it and still make sure that those who are logged into WebEx can actually do a chat with the moderator and come over to us so that we can actually hear their presentations and comments. Again, I'm going to keep my comments limited. I know some of you are anxious to hear about the update to ICD-10, and I will tell you that we are going to plan to do that in the afternoon, basically because we would like to make sure that for all of the proposals that we do have, that we're able to get through all of those proposals so that you're able to provide the comment within the appropriate deadlines. And so with that, I am now going to turn the podium over to Tracy Ramirez, who will introduce our first three topics. Tracy.
Thank you, Donna. We are going to start with some pediatric orthopedic topics, and at this point I would like to introduce Dr. Blazier, who is a pediatric orthopedic surgeon at the Arkansas Children's Hospital, and he is representing AAOS to do the presentations on congenital deformities of feet, as well as juvenile osteochondrosis of the tib-fib, and the flipped upper femoral epiphysis, unstable. At this point, Dr. Blazier, it's all yours.
Good morning, Tracy. Thank you very much. I'm going to be very brief because this is a brief issue. Within ICD-10, there's 9 types of congenital abnormalities of the feet which affect children, and currently only 2 of those types of congenital abnormalities have descriptors which allow specification of right or left. And our recommendation is to simply expand right and left designation to all 9 congenital abnormalities of the feet. And we think this will help with epidemiology as well as medical justification for treatment. And that's our simple request.
Okay, we are going to go straight into the codes. As David's getting them ready, I'll go ahead and start. We are proposing to expand the Q66.0, the congenital talipes of the equivarus, and add a new code at the 00 for unspecified, at the 01 for right foot, and at the 02 for left foot. And at Q66.1, the same, Q6610 for unspecified foot, 11 for right, and 12 for left. As well as Q66.2, congenital metatarsus, primus, varus. We are creating new code at Q66.211 for congenital metatarsus, primus, varus, right foot, at the 212 left foot, at the 219 unspecified foot, and at Q66.22 we are creating a new code at Q66.221 congenital metatarsus adductus, right foot, Q66.222 left foot, and Q66.229 unspecified foot. And moving on at the Q66.3, other congenital varus deformities of feet, Hallis varus congenital. We are adding codes again for unspecified at the 0.30, right foot at the 0.31, and left foot at the 0.32. And as well as Q66.4, the congenital talipes calcio-valgus at the Q66.40 for unspecified, the Q66.41 for right, and the Q66.42 for left, as well as the Q66.7 congenital pes cavis. We are creating codes, new codes at the Q66.70 for unspecified, 71 for right foot, 72 for left foot, and as well as the Q66.9 congenital deformity of feet unspecified, with the Q66.90 as the unspecified foot, the 91 the right, and the 92 the left. Are there any clinical or coding questions?
Thank you.
Thanks, Jean.
Hi. I'd like to ask my orthopedic colleague, isn't the fair number of these occur bilaterally and not in isolation?
If the question is why we don't have bilateral codes and we have right and left?
Well, that was an issue. The Academy certainly supports the concept, but one of the issues that had come up was because these occur not infrequently bilaterally, that it would make sense to have a 4-3 to indicate bilateral instead of having to individually code left and right when both are involved.
We're certainly amenable to that, but I think it has more to do with the precedent within ICD-10. They kind of tend to avoid bilateral codes. Would you care to comment on that?
That was a thought, and we can certainly add that if you feel strongly about that. And if you agree for bilateral?
It's a harmless addition.
Correct.
Yeah. Okay. Thank you.
Thank you, Dr. Linzer. Moderator, I'm sorry, in the audience, are there any more questions? Moderator, are there any questions on the line?
If you have any questions on the phone lines at this time, please do so by using the raise hand feature, and your lines will be unmuted individually. Hi, Erica, do you have a question?
Yeah, this is Dr. Erica Reamer, and I was going to just support that there should be a bilateral. I think there is precedent in other congenital deformities of bilateral extremities.
Okay, great. Thank you so much.
Jean Yoder, Latos, supporting the Defense Health Agency. Bilateral is really a good one for the analysts because otherwise, when you're pulling the data, it will tend to look like either the right foot or the left foot is more predominant. And the real problem is that they're both, okay? So having the bilateral code when you're doing this, because lots of times you only have the first code, then that would make one subservient to the other. So just as an aside.
Okay. Thank you for your input. And since we have no further questions or comments, we will go on to the next topic, which is juvenile osteochondrosis of the tibia and fibula. Dr. Blazier?
Tracy, thank you for your heroism in pronouncing those foot deformity names. Appreciate it. So juvenile osteochondrosis and tibia fibula is kind of, in my opinion, a trash term because it relatively poorly describes what happens in these kids. Can we have the next slide? So there's two conditions, both described by the same code, M92.5, juvenile osteochondrosis. One is Blount's disease, which occurs in kids who are growing, who develop progressively over time, bowing of the legs due to osteochondrosis of the proximal tibia. The second condition, Osgood-Schlatter's, I'm sure you've all heard of, is more or less a painful tibial tubercle oftentimes related to sports activity in children who are growing. So they both have the same code, but they really are different diseases, and our plea is to make new codes which describe both of them. And there's another slide so you can see this. The Blount disease is on the left, bowed legs and a growing kid, and on the right, the Osgood-Schlatter's condition. Tracy?
Thank you, Dr. Blaser. Okay, let's go to the coding proposal. And like Dr. Blaser said, these two conditions are actually very different. Therefore, we are breaking them out and creating separate codes. So at the M92.5, we are proposing to delete the two inclusion terms and making them their own subcategory. At M92.8, we are going to create, we are going to delete where it says calcaneal apophysitis. I know that's wrong. I'm sorry. At M92.81, we are going to add, that would be a new subcategory for juvenile osteochondrosis of the proximal tibia, Blount, and adding the inclusion term of tibia vera, and adding new code M92.811, juvenile osteochondrosis of the proximal tibia, Blount right leg, 0.812 for the left leg, and 0.819 for the unspecified leg. And at M9282, creating new subcategory for juvenile osteochondrosis of the tubercle, and in brackets, Osgood-Schlatter's. At M92.821, we're having the right leg. At M92.822, the left leg. And at M92829 for unspecified leg. And creating new code at M9289 for other specified juvenile osteochondrosis to include the inclusion term of the calcaneal, how do you pronounce that? Apophysis. Okay. Jean.
And Jean Yoder, of course, the same thing, if there's a possibility of it being bilateral, the condition after study, golly, which one, the right or the left one's worse? If
Yeah.
you just have a chance of bilateral.
Okay.
Oh, okay.
Dr. Lancer, you agree? Okay, great. Are there any other clinical or coding questions in the audience? Moderator, could you open the phone lines?
If you have any questions at this time, please do so by using the raise hand feature. Your lines will be unmuted individually. Thank you.
Okay, no questions. We will continue with the proposal on slipped upper femoral epiphysis for unstable. Dr. Blaser?
Thank you. This one's slightly more involved, and I'm going to say right up front, we have no objection to making them bilateral codes. Next slide. So slipped capillofemoral epiphysis is a disease, again, which affects growing children. And the hip is kind of a ball and socket affair, and just below the ball in the socket is the growth plate, which in the kids who are affected with this condition, they have softening of the growth plate, and the head of the femur gradually slips off the shaft of the femur, resulting in deformity. Next slide. And this can occur slowly as a chronic condition, takes a long time with gradual changes, or it can be acute, sort of a sudden onset, wasn't there before, or acute on chronic, where it was going on for a while, then had a sudden worsening. So in the past, these slips were described within ICD-9 and ICD-10 based upon chronic, acute, and acute on chronic. But since this classification system was developed, it's found that chronicity is not so prognostic as stability. If you go on to the next slide. And stability means that this upper head of the femur, the ball of the ball and socket, slips off so hard and so acutely that the patient looks more like they have a fracture. They're in terrible pain, they can't walk, and they're in danger of losing the blood supply to the head of the femur. And this occurs in the acute and acute on chronic conditions only. And the ones that are unstable tend to have a terrible prognosis, where those are stable have a good prognosis. So our initiative then is to make new codes which describe stability versus instability, stable versus unstable, and apply those only to the acute and acute on chronic. They're not necessary for the chronic. So the initiative is stable versus unstable in acute and acute on chronic, right and left, unspecified, and we have no objection to bilateral. Tracy?
Okay, if we could turn to page 58 in the topic packet. The first 4 revisions that you're seeing are revisions because looking at this, we noticed that the unspecified hip was at the 3 category level. So we are changing that to make it in all these at the point, or the 009, or the 019, or the 029, or the 039. This is kind of an incidental finding, so we are making those changes. So we are proposing to add new subcategory M9304 for acute slipped upper femoral epiphysis, unstable, non-traumatic, with the 041 for the right hip, the 042 for the left, and the 049 for the unspecified. And as Dr. Blaser said, we will add one for bilateral as well. Again, at the M9305, we were proposing to create new codes for acute on chronic, slipped upper femoral epiphysis, unstable, non-traumatic. Again, at the 051 right, 052 left, and 059 unspecified. Dr. Linzer.
Yeah, Jeff Linzer, AAP. We certainly support the proposal and appreciate the inclusion of bilateral terms. We would suggest, for clarity's sake, that at the M9301 and the M9303, the term stable be added, since you have unstable on the others.
Okay.
So that would help, I think, prevent confusion.
Okay, great. Any other questions or comments in the audience? Moderator, could you open the phone line if there was any questions?
If there's any questions at this time, please do so by using the raise hand feature, and your lines will be unmuted individually.
Okay, as there is no more questions, thank you, Dr. Blaser. It was a pleasure. I'm going to hand over the podium to Donna Pickett.
Okay, if you will go to page 16 in the Part 2 topic package. The topic of the electronic nicotine delivery systems was last presented at the March 2017 meeting, and we've received a lot of comments on that particular proposal. Part of that proposal was also to expedite the implementation of the code, but based on the comments that we had from stakeholders, we could not go forward with that part of the request. What we've done is try to incorporate the many comments that we've received, and when I say many, I am not exaggerating. And what we also did was to take a step back, look at the proposal that was originally submitted by the American Thoracic Society, and look at the comments that came in that were not specifically related to e-cigarettes. There were many commenters who wanted us to also consider the use of marijuana or other substances as part of the electronic devices. And that can be taken up, but that would have to be taken up as a separate proposal, as this was not the intent of the ATS's original proposal. So the proposal here before you is revised based on stakeholder input, but also we wanted to make it clear that we were totally focusing on the original proposal and took in those comments that were related to nicotine. The new codes that are being proposed do parallel the existing codes, and so we were just modeling it on what was there, but making it clear that this was specific to the electronic delivery systems. The other thing that we tried to do with this proposal was to incorporate additional terminology that many indicated was actually being seen in medical records. So vaping, things of that nature, we tried to include those here. And again, we were starting from this, but we knew that we would be receiving additional comments. And just to let you know, every single index entry that could be affected by this proposal, we are not showing at this time because we wanted to make sure that we had the tabular modifications and its new codes for you to review before we looked at the indexing implications, which are quite wide, particularly with many of the other terms that people wanted to see included as part of the modifications to the classification. So again, since this was presented at the March 2017 meeting, we have not gone back and incorporated all of the clinical information that was previously presented. That is still on the website for your review if you need a refresher in terms of what the original proposal looked like. I'm not going to read through all of the codes, but one of the other comments that also came in was whether or not the codes at 099.3 should be modified to take into account the use of the electronic nicotine delivery systems in pregnancy. And we did have input from ACOG that they believe that it should, so you'll see that reflected in the proposal as well. Now, we could not, because of the structure, have a whole unique section that specifically addressed ends separately from tobacco, so we have made a revision to the code titles. One, to make it clear that we are talking about tobacco, but we're also talking about nicotine, which would include the use of the electronic nicotine delivery systems. And also changes at the T6523. Again, you'll see there that what we've done is to add a number of inclusion terms there so that when you get to the code, you realize that you are in the right place. Again, we may have missed a few special perspective inclusion terms, so if there are others that one would like to see, those should certainly be considered as well, but also to remind people that the includes terms are things that are such as or for example, so it is not intended to be an exhaustive list, and some of the things could very well end up in the alphabetic index. But again, trying to incorporate everyone's perspectives on this, we wanted to have you see what the revisions might look like and invite your input on that as well. And I can see people kind of pondering, okay, what was missed and what else could we add? And so we absolutely will appreciate your comments here at the meeting today. But of course, always we appreciate your comments in writing. Also changes at Z720. We've expanded that to 5 character codes. So that it is now split for Z7201, tobacco use, Z7202 for ends. And then, of course, we typically have an unspecified, because sometimes it's been pointed out that you don't have much more information than the person is using a device, and you don't know what's in it. So we did give some thought to that and included an additional code for unspecified. So with that, and we do have with us today Dr. Gary Ewert from the American Thoracic Society, and so if there are clinical questions or any issues that ATS can handle, he is here to assist with those questions as well. And so with that, I'll ask if there are any clinical questions here in the audience. And so far, seeing none, moderator, would you please open the lines to see if there are any clinical questions from those participating through WebEx?
If you have any questions at this time, please do so by using the raise hand feature, and your lines will be unmuted. Thank you.
Okay, hearing no questions from WebEx participants, again, we would dearly love to have your comments in writing to us by the deadline. And we much appreciated your previous comments, which helped us to modify the classification for this particular presentation as proposed. And we do have someone coming to the microphone. Sue?
Sue Bowman from Mahima. I was waiting for you to get to the comments on the coding part.
Okay, well, I wanted to do the clinical first, but hearing none, again, now we can go to comments on the coding part. Thank you.
Just one comment. I really appreciate the revisions to the structure. I think it's much improved from the previous proposal. I do know that we've gotten a lot of questions at AHIMA and at the EAB about the use of these products and weaning people from tobacco and so on, and I know it says in the proposal this does not cover that. I wonder if we should have any instructional notes to make it clear that these codes should not be used for that kind of use of e-cigarettes, just to make sure no one is incorrectly using these codes for the nicotine replacement therapies under medical supervision kinds of situations.
That's a good thought that we'll take on board. So in the write-up, we do mention that, we were not looking at this from the perspective of treatment. So things like ENDS as a replacement therapy, the use of nicotine patches, none of those were to be part of this. And in fact, those would be considered services or treatment and not actually part of the diagnosis. But that's a good point, that perhaps we do need to consider some notes that make that clear. And we could also include it, should these codes be approved, it could also be included in the revision of the coding guidelines if necessary.
Jean Yoder, LIDO Supporting Defense Health Agency. I'm looking at this and I'm thinking that when I look at data, I'm thinking, okay, now we're only supposed to collect those things that impact that episode of care. And so for a lot of particularly young people, if it's not impacting that episode of care, but they're using it, I'm just trying to make sure that we don't start collecting data because a code is there, but not that it impacts the episode of care. And oh well.
Thank you for those comments, Jean.
Hi, June Bronner, IMO. I have a couple questions, and one is, and maybe this will come with more of the indexing, but if the substance isn't specified in the electronic delivery, is this the thought of the code section of where, as a default, when the substance isn't specified, if there's more in the e-cigarette than just the nicotine or tobacco, but it's not really stated in the documentation.
Okay, so you think that would be something maybe we should just handle by indexing
Or clarify.
Or at least to
yeah,
have a
just
default.
Potentially, or just the
Okay.
clarification so people know what is the default. And then the other question is related to the obstetrics codes. The titles say smoking and include tobacco and nicotine. Was there thought given to changing the title from smoking to as the other? Or is it really considered smoking by using the?
So maybe the thought, June, is to kind of broaden that so that it's not,
Yeah.
so it's more encompassing of all the different mechanisms that, okay.
Yeah, yeah. Thank you.
Thank you, June. Any other comments on the coding proposal itself in the audience? Moderator, could you open the WebEx line for any questions or comments?
All lines are now unmuted.
Okay, hearing none, I know everybody is contemplating what their comments will be, and so we'll look forward to receiving those comments by November 13. And if there are no other comments from the floor here, we will now turn it over to Shannon, who will lead the discussions on the next set of proposals.
Good morning. The next topic is in packet 1, and it can be found on page 56. The topic is Sjögren's syndrome, and today we have Dr. Alan Bayer from the Johns Hopkins Jerome L. Green Sjögren's Syndrome Center here to provide the clinical background for us. I'm hoping this works. Let's see. No, doesn't work. Okay. Okay, maybe he's going to just say next slide and hoping he'll move it. We'll see. Hope that works.
So thank you very much, Shannon. I'm here on behalf of the Sjögren Syndrome Foundation and the American College of Rheumatology. Next slide, please. Okay, let me try again. There we go, actually. So Sjögren's syndrome is a chronic, systemic autoimmune disease that primarily affects women. Its cardinal manifestation is the autoimmune-induced inflammation of the glands that produce tears and saliva, and this results in profound dryness of the eyes and mouth and other mucosal surfaces. But we need to emphasize that this disease affects many other organ systems, including the skin, the joints, the lungs, the kidney, and nervous system. And importantly, people who have Sjögren's syndrome have a significantly increased risk of developing lymphoma. It occurs in about 5 to 10% of those affected. So this figure just shows the many ways in which Sjögren's syndrome can affect other organ systems in addition to the glands that produce tear and saliva. And again, just to emphasize that this is a systemic disease, multiple organs can be affected. Patients frequently report pain, fatigue, and cognitive impairment, which they often report as brain fog. There is an increased risk of lymphoma, as I mentioned. There are autoantibodies in the blood in high concentration, and blood counts are often abnormal. So all of these emphasize the systemic nature of this disease. Now we're here today to ask that the term sicca syndrome, which is currently the ICD-10 code for Sjögren's syndrome, become secondary, and that Sjögren's syndrome becomes the primary terminology for this disease. And I thought I'd provide a little history of the terminology that has been used. So Heinrich Sjögren was a Swedish ophthalmologist who in 1933 first described 19 women who all had this profound dryness of the eyes and also reported that there were other systemic manifestations. And he termed this entity keratoconjunctivitis sicca, really emphasizing the ocular involvement. And then before his death in 1986, this entity had really become known as Sjögren's syndrome. There were studies at NIH in the early 60s in which it was clearly reported as Sjögren's syndrome. And the term sicca syndrome has, over the years, had multiple meanings. It was actually used by Sjögren himself before he died, and there was a publication in 1956 in which he used the term sicca syndrome. It has been reported to report just dryness of tissues other than the eyes, and it's also been referred more commonly as dryness of the eyes and mouth in the absence of another systemic rheumatic disease such as rheumatoid arthritis. That's the medical subject heading database of the National Library of Medicine and how it's defined. So the current concept of sicca syndrome is that it simply denotes the presence of dry eyes and dry mouth without specifying a specific cause. And so what I'd like to emphasize is that many affected patients who have sicca syndrome do not have an autoimmune basis for this. Sicca syndrome, thus, is really an outdated term and is no longer synonymous with Sjögren syndrome, and it overlooks the systemic manifestations of Sjögren syndrome. And if you look at the literature, there are a variety of reported causes for sicca syndrome. This is a list of the many. It can occur as a result of age. It can result of medications, which is perhaps the most common, radiation treatment, and there are a number of other inflammatory diseases of the tear and saliva-producing glands that can also produce sicca syndrome. So perhaps the most striking evidence to support our claim that really we should be using the term Sjögren syndrome is if you look at the use of these two terms in the medical literature. This is a PubMed search for the term Sjögren syndrome shown in the right panel and sicca syndrome in the left panel. You can see that Sjögren syndrome is clearly the preferred term. There are very few citations for sicca syndrome in the medical literature since 1939. So clearly Sjögren syndrome is the preferred terminology. And this just highlights that the sicca syndrome is used in the medical literature really to describe a variety of different disorders, not necessarily Sjögren syndrome, in which there's dryness of the eyes and mouth. So just to finalize here, so we are making the strong case that Sjögren syndrome is not sicca. Sicca is really a symptom, it's not a disease. Sjögren syndrome, on the other hand, is a distinct and prevalent systemic autoimmune disease that affects multiple organs and body systems. And sicca can arise from a variety of different etiologies. And dryness is just one symptom that can occur in Sjögren syndrome, but does not represent a disease in its entirety. So the requested change that we are making today is that we would like to make Sjögren syndrome the main heading for M35.0 and only keep sicca syndrome as an inclusion term. And as a secondary request, we'd like to increase the granularity of the subheadings so that we can identify some of the more common systemic manifestations of this disease. And so we're asking that there be inclusion of inflammatory arthritis, peripheral nervous system, central nervous system involvement, gastrointestinal involvement, glomerular disease, vasculitis, and dental involvement in the M35.09 category. So I'd like to thank all the people who have helped put this request together, and I'm happy to take questions or move on from here. Thank you.
Thank you. Are there any clinical questions before we go into the tabular modifications? Okay. All right. If we could please switch over to the tabular modifications. Okay, so the proposed tabular modifications, which will be coming up shortly, are at category M35, other systemic involvement of connective tissue, to revise M35.0 to read Sjögren syndrome, to add an inclusion term, sicca syndrome, and to revise the existing codes M35.00, .01, .02, .03, and .04 by replacing sicca with Sjögren's syndrome. We would also be creating a new subcategory and revising the current code M35.09 to read Sjögren's syndrome with other organ or system involvement. And as Dr. Bayer listed, the requested new codes showing on the screen M35.091, 92, M35.093 for the Sjögren's syndrome with central nervous system involvement, M35.094, 0.95, the 0.96 for the Sjögren's syndrome with vasculitis, M35.097, and M35.098 for Sjögren's syndrome with other organ or system involvement. Are there any coding questions? Dr. Linzer?
AAP. We certainly support the concept of using more modern terminology in the code set. I wonder, though, if instead of leaving sicca syndrome as an inclusion term at this point, since it's so broadly used, is if perhaps the term either is pulled out and perhaps pointed to an R code, or that there's a clarification that this sicca syndrome is associated with Sjögren's, so that it's not miscoded.
Okay, and good point. I know that for the sicca, we do want to make sure that we index that going to the R codes. For the sicca syndrome, we were actually aligning with ICD-10, which has sicca syndrome as an inclusion term. We can definitely take that back and see if further breakout is needed. But
So you may want to look at an excludes code
to exclude
to separate.
Okay.
Yeah.
Thank
The other
you.
question I have for the presenter is that patients can present with multiple presentations. Am I correct?
Yes.
So how would you propose that a patient who has several of these involvements be coded?
Actually, I'm not a coder, so I would have to ask the,
Well, I mean, the
But, I mean,
question
that-
is, if they have vasculitis and glomerular disease and keratoconjunctivitis, then would you expect then all three to, thank you very much. Or would it be reasonable to have a unique code that just indicates multiple organ involvement? Okay, you guys can list 6 things at one time, that's okay. Just asking.
so I know, I mean, that conundrum already exists in the current codes for sicca syndrome, which is that they list several manifestations, and as a clinician, I face that difficulty as well, of whether you list more than one or just list the primary one for which the visit is focused.
And I would strongly suggest your society educate your providers when they are identifying multiple applications of this condition to clearly indicate which they think is the most severe so that the coders can identify the principal out of the group.
No, that's an excellent point. Thank you.
Thank you.
Nellie Leon, Chisane American Hospital Association. I think doctor makes a very convincing case to make the change, but it sort of took me to the other extreme because now I'm wondering whether sicca syndrome and Sjögren syndrome are so widely different, where one is the old terminology is more of a symptom of an eye condition, and so whether they are so different that they may need different codes as opposed to just changing the title of the existing codes. Or do you not care? I mean, because you think that in the end, they were really talking about the complete syndrome. It's partly clinical, partly coding
Right.
question.
So, doctor, can you clarify sicca as a symptom versus the sicca syndrome, which is still looked at under that umbrella for Sjögren's? That's what I need to know. Do you understand what I'm saying?
Yeah, he did too good of a job
'Cause when you say
convincing
sicca,
us.
If sicca is indeed just a symptom, we will send that to an R code for ill-defined symptoms.
Right.
But if it's sicca syndrome,
Yeah, I mean, there are, so I think sicca is a symptom, and so you could clearly code dry eyes and dry mouth separately. So the combination of dry eyes and dry mouth is why it leads to something called sicca syndrome. And it's perfectly reasonable to ask whether that should be a separate code or a symptom code. I notice that there are other conditions, for instance, when people have ulcers both of the mouth and of the genitalia, that's sometimes called complex aphthosis, which it's not necessarily Behçet syndrome, but it represents a condition in which there are 2 different sites that are being involved simultaneously. So I would actually prefer to get rid of the term sicca syndrome altogether, but I think we're limited in what we can do.
okay, we will take that back and look at if indeed there's a way to break that out, and maybe just a slight deviation from what we will see currently that's there for ICD-11. Thank you, Dr. Linzer, as well as Dr. Nellie, for the comments. Dr. Bergman, you want to comment?
I was just going to comment, maybe we could try something like a term that would say sicca syndrome, meaning Sjögren syndrome, go to the Sjögren syndrome, or meaning dry eyes and mouth without Sjögren syndrome, go to the R code. That's might be a little bit unclear, but I think part of the problem is the term sicca syndrome now could mean something different than it meant 50 years ago or even 20 years ago. And I think the thinking 20 to 30 years ago when ICD-10 originally was created was leaning back on the thinking from 50 years previously to now, and it's not reflecting how the term's been used more recently, I'm afraid. And I'll ask for, does that sound about right, or
No, I think it does sound right.
Yeah, okay.
Again, sicca syndrome just is the combination of dry eyes and dry mouth.
Yeah.
Of many different potential causes, of which Sjögren's is one.
So sometimes we use a term such as meaning this or that in our index, and I think that might be the more appropriate approach. You sort of have to presume, if you have the term without any other indication, that it means one or the other, but we can use the term meaning and then just go from there and hope that the documentation will make clear more or less which one the clinician intended if they use that term.
Thank you.
Thanks.
Thank you, Dr. Berglund. So at this time, I'm going to ask the moderator if you could please open the lines for any questions or comments on this topic.
If you have any questions, please do so by using the raise hand feature, and your lines will be unmuted.
Okay, I'm not hearing any. I'm going to go ahead and ask you to please close the lines, and we will move on to the next topic. Dr. Bayer, thank you very much. Appreciate it. We'll be back in touch with you. Okay. The next topic, again, it's in part 1 of the packet, and it's on page 17. The topic is BRCA. This proposal was originally presented at the March 2018 Coordination and Maintenance meeting. The proposal has been revised based on public comments received following the meeting, and the following new codes are being requested to identify BRCA mutation for statistics, tracking, and reporting. The changes are shown in bold, and ACOG has reviewed and does support this proposal. The proposed tabular modifications are at category Z15, genetic susceptibility to disease, at subcategory Z15.0, to create a new subcategory, Z15.01, genetic susceptibility to malignant neoplasm of breast, with the following new codes: Z15.11, BRCA genetic susceptibility to malignancy of breast, Z15.012, and Z15.019, genetic susceptibility to malignant neoplasm of breast unspecified, with the inclusion term BRCA NOS. And creating a new subcategory, Z15.02, for genetic susceptibility to malignant neoplasm of ovary, with the following new codes: Z15.021, BRCA1 genetic susceptibility to malignancy of ovary, Z15.022, and Z15.029 for genetic susceptibility to malignant neoplasm of ovary unspecified. Are there any comments or questions here in the auditorium? I see one that may be coming. I'm sorry. Comments for the, yeah, can you please? Comments, questions?
And I guess this is a mix of a clinical encoding, and hi, June again. Is BRCA limited to just the breast and the ovary as causing potential cancer? Because which I don't think it is, I believe
Right,
there's
it's not.
other organs. And was there thought or consideration given to the category for multiple genetic susceptibility to multiple neoplasms and having the BRCA listed under there versus, because the way I see this now is for every potential susceptible neoplasm, if BRCA is just documented, the coder would have to go through and pick up the various Z codes for each organ, correct?
Correct.
I mean,
So when we got the feedback, and there was the comment that was sent in during the comment period, requesting perhaps using multiple as well as for the fallopian tubes, because indeed it does hit other sites. And the feedback that we got was, although they are important, there's no need for the additional codes at this time. So the focus was on the breast and the ovaries for this particular time. But again, if you can please put those comments again in writing, we will definitely go back to ACOG and see if it should be looked at with a little further expansion.
great, thank you.
And Dr. Berglund is coming up to add a little more information.
Weigh in on this, Mike. I think you raise a very good point here, and it is a little bit of an issue. We currently have existing codes that essentially tell us this person is susceptible to, genetically susceptible to a malignant neoplasm of the breast, or this person is susceptible, genetically to a malignant neoplasm of the ovary. We have not had codes that say this person has BRCA1 or this person has BRCA2. We're essentially trying to introduce codes that overlap that way. It sounds kind of like you're suggesting maybe we need to think about it. Should we create a new separate category or subcategory somewhere that would be this person has BRCA1, and maybe we'd use that with one or the other of the other codes at the same time. Now, that gets problematic, and certainly someone can have BRCA1, and if they have a double mastectomy, then they're probably no longer so susceptible to get breast cancer because their breasts were removed.
Right.
Or if they had their ovaries removed, then they're no longer susceptible to that.
Yeah.
Or if they're a male, they might be susceptible to breast cancer, but they're not going to be susceptible to ovarian cancer.
Correct.
So there's different things like that that we don't always think about, but that maybe we need to sort out. So we'd be glad to take comments on that and think about something completely new and different, so to speak.
Yeah, and especially as genetic medicine keeps evolving and we keep discovering through the various projects, it does raise an interesting dilemma on how to capture that as we go forward, or topic.
Yeah, that would be different from what we're proposing at this time. I guess we're willing to entertain that idea. We don't quite know what it would look like.
But yeah, no, that's fine. And like I said, I just wanted to raise that, and because I can see this, like I said, as we discover more genes and causing different and various diseases, and how does the system approach it in general. So thank you. Appreciate it.
I'll pass it back to you.
Are there any other comments or questions here in the auditorium? Okay, moderator, could you please open the lines for any questions or comments?
If you have any questions or comments at this time, please do so by using the raise hand feature. Your lines will be unmuted individually.
Are there any questions or comments on the line?
At this time, there are none.
Okay. At this time, I'm going to turn the podium back over to Tracy Ramirez for the next topic.
Okay, remaining in the part 1, please turn to page 19, and we are going to go over the breast lump in overlapping quadrants. The National Center for Health Statistics has received numerous proposals requesting new ICD-10 CM codes for breast lump in overlapping quadrants, right and left breast. The proposed codes would align the structure with the current codes for malignant neoplasm of breast, for example, in category C 50.8. The proposed codes would allow for proper code assignment when an unspecified lump in the breast overlaps anatomic sites classifiable to different codes. The American College of Obstetricians and Gynecologists has reviewed and supports this proposal. So we are proposing to add 2 new codes. David, could you page down? I'm showing you the existing codes as they are. So the new code would be N6315 for unspecified lump in the right breast, overlapping quadrants, as well as N63.25, unspecified lump in the left breast, overlapping quadrants. Are there any comments or questions from the audience? Moderator, could you open the phone lines?
If you have any questions at this time, please do so by using the raise hand feature, and your lines will be unmuted.
Okay. Now, we're going to move on to fetal anomalies on page 35. The American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine are proposing that code category 035, maternal care for known or suspected fetal abnormality and damage, be expanded to provide specificity for appropriate diagnosis and to assist in measuring the incidence of these specific anomalies. This will enable better tracking, measurement, and ultimately treatment for identified fetal anomalies. Assignment of trimesters is not applicable at the fetus-specific codes, as the fetus-specific codes can be deleted from the code section. A separate Z code identifying the fetus number is also being proposed in a separate code proposal. David, can we go down to the modifications now? So they are proposing to delete the note of one of the following 7th characters. That is actually going to be in the following proposal, as well as delete the inclusion terms at 035.0, as they will become full codes. Next page, David. So they are requesting new code 03500 for maternal care, suspected central nervous system malformation in fetus, unspecified. Also one for a genesis of the callosum at 035.01. At 035.02, they are requesting maternal care for suspected central nervous system malformation in fetus, anencephaly. At 0.03 for choroid plexus cyst. At 0.04 encephalocele. At 0.05 holoprosencephaly. At 0.06 hydrocephaly. At 0.07 microcephaly. At 0.08 spina bifida. And at 0.09 other specified. Moving on to 035.1, maternal care for suspected chromosomal abnormality in fetus. The 0.10 would be the unspecified. The 0.11 would be the trisomy 13, 0.12 trisomy 18, 0.13 trisomy 21, 0.14 Turner syndrome, 0.15 chromosome abnormality, and 0.19 other specified. At the 035.2, David? New code at 035.20 for maternal care for suspected hereditary disease in fetus, unspecified at the 2.1, inherited metabolic disorder at the 2.9, other specified. And new category 035.A, maternal care for suspected cardiovascular anomalies in fetus. At the A1, maternal care for suspected congenital malformations of cardiac chambers and connections in fetus. At the point A10, common anterior trunk. At the A11, the double outlet right ventricle. At the A12, double outlet left ventricle. At the 814, the discordant ventricular arterial connection with the following inclusion terms. And at 035.818, maternal care for the other specified in that category. Next page. As well as 035.A19 for the unspecified. And then the new subcategory at 035.A2, maternal care for suspected fetal congenital malformations of the cardiac septa. At the A20 for the atrial ventricle septal defect. At the A21 for the tetralogy of Fallot. At the A28 for the other specified. At the A29, the unspecified. And moving down to at the 035.A3, we are creating new subcategory for maternal care for suspected congenital malformation of pulmonary and tricuspid valves in the fetus. At the A30, Epstein's anomaly. At the A31, hypoplastic right heart syndrome. A38, other specified. At the A39, the unspecified. And moving down to 035A9, maternal care for other specified congenital malformation of cardiovascular system in fetus. At the A90, hypoplastic left heart syndrome with intact restrictive atrial septum. At the A91, the total anomalous pulmonary venous connection. At the A92, heterotaxy syndrome. At the A98, the other specified. At the A99, unspecified. And at 035.B, maternal care for suspected pulmonary anomalies in fetus. Maternal care at the point B0, the unspecified. The point B1, congenital cystic lung. The point B2, sequestration of lung. At the point B3, agenesis of lung. At the point B4, congenital diaphragmatic hernia. At the point B9, other specified. Page down. Thank you. At the 035.C, maternal care for fetal muscular skeletal anomalies in fetus. At the point C0 is unspecified. At the point C1 is anomalies in fetus exomphalos, with an inclusion term of omphalocele. And at the C2, gastrosis, gastroschisis. At the C3, the upper extremities. At the C4, the lower extremities. And the C9, other specified. And moving on to 035.D, maternal care for suspected genital urinary anomalies in fetus, with the D0 unspecified, the D1 renal genesis of other reduction defects of kidney, the D2 cystic kidney disease, D3 congenital obstructive defects of renal pelvis and congenital malformations of the ureter, the D4 congenital megaureter, at the D5 extrophy of urinary bladder, and at D9, the other specified. At the 035.8, we're adding a new code, 035.80, for maternal care for suspected other abnormality and damage, non-central nervous system marker, or anomalies in fetus unspecified. At the 035.81, we are creating code for the facial anomalies in fetus within the following inclusion terms. At the .82, the gastrointestinal anomalies in the fetus, with breakout of new code 035.820 with tracheal esophageal fistula, and the 821 gastrointestinal anomalies in the fetus, congenital atresia and stenosis of small intestine, with the following inclusion terms, as well as the 035.828, the maternal care for suspected other abnormality and damage, gastrointestinal anomalies in the fetus, other specified, excuse me, and a new code for the .29 for the unspecified. Next page, David. And at the 035.8, a maternal care for other suspected fetal abnormality and damage, with the following inclusion terms. And new code at 035.89 for the unspecified, with the inclusion term of maternal care for suspected other fetal abnormality and damage, congenital cystic hygroma. That was a mouthful. Are there any questions from the audience?
Nellie Leon, Chisane American Hospital Association. I guess, and maybe you can't answer this, and maybe this is a question for ACOG, but it sounds like they are not interested in identifying the fetus number for this category of codes. But we do know that there are about 9 other categories, all the way from 031 to 069 and so on, where we do have this structure for identifying the fetus number. Is there something different about this category 035, or is this kind of an indication that they might have future proposals for the other categories? And I know I'm jumping a bit ahead for the other tab where there's a proposal for Z codes to identify the fetus number, but it just seems a little odd to do it here, but leave the other ones. And so actually I'm going to say something a little bit radical, because if there is no interest of identifying which fetus is affected, then why would we want to collect that information with a Z code then?
Okay.
Maybe just get rid of it altogether. but it would have to be something that is intentional, carefully thought out, and applied across the different categories where this concept exists.
Okay, I will take that question back to ACOG. Jean?
Jean Yoder, I see under 035, it has a code also, any associated maternal condition. And so I'm looking at this and I'm thinking, okay, so a previous exposure and, like an exposure to Zika or something like that, it would have to be never mind. I'll go back and sit.
Make sure you put that in writing. Okay. Okay. Moderator, could you open the phone lines?
If you have a question at this time, please use the raise hand feature and your lines will be unmuted individually. Hi, Teresa, do you have a question?
Yes, this is Teresa Rahanek from Intelligent Medical Objects. And I'm looking at the pattern, the structure here at when you get to 035.8, it seems that the pattern for the unspecified and the non and the other gets broken. It gets out of whack. At the 035.820 should probably be the unspecified, and then you shift them down according to the pattern that we have already established in ICD-10. And I'm also wondering, what is 035.80 supposed to represent? A non-central nervous system marker or anomaly in fetus? What is that? Is there any instruction? 80. What is that code trying to represent?
The the non-central nervous system markers and anomalies in fetus.
What is that?
Yeah.
I think that code title needs clarification as to what's supposed to be classified there.
Okay.
And I also echo Nellie's concerns about the fetus number. Thank you.
Okay, thank you, Teresa. Sue.
Sue Bowman from HEMA. And I guess my one comment will be, I remember the day not too long ago, physician groups were very worked up about the degree of specificity in ICD-10 CM. I guess they're not so concerned about that anymore. But I just hope that the clinicians, are committed to, they're going to document to this level of detail, because to me this seems like an incredible level of detail for, a fetal level, that has not been born yet. So I just hope that these codes end up actually being used. And I had a few comments regarding the fetus number, but I was going to wait until you get to that.
Okay.
Describe that actual proposal.
Okay.
And to answer your question, Sue, yeah, with the ultrasounds nowadays, they do get to that degree of specificity.
And they're going to document.
Mm-hmm.
You're recorded,
Yes, I am.
Okay, we will move on to the next one, which is on page 43, the fetus number. Again, ACOG and the Society for Maternal Fetal Medicine are proposing new category at Z3B, fetus number affected by fetal anomalies, for Z3B1 for fetus 1, point 2 for fetus 2, point 3 for fetus 3, point 4 for fetus 4, point 5 for fetus 5, point 8 for other specified, and point 0, excuse me, for unspecified fetus number.
Sue Bowman from AHIMA, and I'll just echo Nellie's earlier comments. It seems to me from this proposal that sort of moving into we don't really care about this particular information. So my concern is having a different structure for capturing this information for future codes than we have for the existing codes already in the classification. So I think we either need to do it one way or the other, or a third way, which Nellie sort of proposed, of getting rid of this concept altogether. But either we need to keep it in the 7th characters the way it is now in the other categories, or everything, all the 7th characters need to be deleted, we need to use the Z codes, or, which would actually be my preference at this point, we just get rid of that concept altogether, because one of the things that this structure obviously does not capture that the current structure does is which fetus has which congenital anomaly, which you're not really capturing with this.
Right.
And it's and also this structure, it appears to me that you would only assign it for multiple gestations because it doesn't have the not applicable 0 option that the 7th characters have, but it doesn't say that either. It just says fetus number affected by fetal anomalies. So if it's a single fetus, are people going to think that they need to put the Z3B.1 on that one? Or if this is only intended for multiple gestations, I think that needs to be clearer in the category title. But my preference would be that it just seems to me people aren't really interested in this information, and let's not monkey around with it and just get rid of it.
Okay. Okay.
Lynn Keene Consulting, I want to echo what Sue said, but I think that rather than to deal with the code title here, this just needs one of those coding notes that you often find in the OB chapter that says that this is applicable only to the multiple gestations. Do not assign Z3B1 for a single gestation. Otherwise, we're going to have this all over the place.
Okay.
Thanks.
Great. Moderator, can you open the phone lines?
If you have questions at this time, please do so by using the raise hand feature, and your lines will be unmuted. Hi, Erica, do you have a question?
Yeah, this is Dr. Erica Reamer. Yeah, I find this whole fetal number problematic. I think that it depends on what they really want. If they want to know which fetus has which thing, then we need to have it attached to the code and not do it as a separate Z code, because you won't be able to tell which fetus has which anomaly. I think we need to go back and explore it a little further with ACOG.
Okay, great. Thank you so much. Please make sure you put that in writing. Any other questions from the audience? Okay, let's turn to page 22 in part 1. Cyclical vomiting syndrome. This is a representation of maybe 3 times, and this one does incorporate the last public comments, and therefore I'm going to just go over those, and that is adding the word in migraine at the G43A0 as well as the G43A1, and adding at the R1115 NOS, and at the excludes note at the R1115, the excludes 1 for cyclical vomiting, and adding the word in migraine. And hopefully that will be acceptable. Some shaking of heads. Dr. Linzer.
I think in our comments, if I recall correctly, we also asked for an inclusion term at the R1115 to have the old persistent vomiting.
Say that again, I'm sorry?
I think-
Can you talk into the mic?
No.
Okay.
I think that we had requested at the new code that the term persistent vomiting be added as an inclusion term
Okay.
for consistency with 9.
Okay. Moderator, could you open the phone line?
If you have a question, please use the raise hand feature and your lines will be unmuted individually.
Okay. As there are no further questions or comments, I am going to turn it over to Cheryl Bullock.
All right, good morning. The next couple of topics will be that were submitted from the American Academy of Pediatrics. The first one can be found on page 54 in your topic packet, neonatal cerebral infarction. Neonatal cerebral infarction or stroke is a cerebral vascular condition that occurs between 20 weeks of fetal life through the 28th postnatal day. This condition results in ischemic or hemorrhagic injury around focal or multifocal cerebral vessels in which there's a disruption of the cerebral blood flow, which is secondary to either a venous thrombosis or embolization. It is frequently diagnosed by CT scan or MRI in neonates with neurological findings such as seizures or asymmetric neurologic tone. It is most often found in the right or left middle cerebral artery distribution, and most often, but not exclusively, unilateral. Laterality is important to document for epidemiological prognosis and follow-up. The Academy requests the following tabular modifications. At P91.8, other specified disturbances of the cerebral status of newborn, new subcategory P91.88, other specified disturbances of cerebral status of newborn, with a new subcategory of neonatal cerebral infarction, with 2 excludes notes, and excludes 1, cerebral infarction at I63 point dash, and it excludes 2, intracranial non-traumatic hemorrhage of newborn at P52 point dash. There are 3 inclusion terms that are being proposed: neonatal stroke, perinatal cerebral infarction, and perinatal arterial ischemic stroke. The new proposed codes would include laterality, P91 8.8811, neonatal cerebral infarction of the right side, 8812, left side, 8813, bilateral, and 8819, unspecified side. Are there any questions or comments from the floor? Not hearing any. Dr. Linzer. Moderator, could you open the phone lines, please?
All right, thank you for your help. If you have any questions at this time, please use the raise hand feature and your lines will be unmuted.
Are there any questions from the phone lines?
Hi, Teresa, do you have a question?
Yes. Cheryl, this is Teresa Rahanek from IMO, and I just have a comment on, I don't have any problem with these codes, but instead of building out P9188, you still have room at P91 to go P9182 and build out their cerebral infarction there, rather than expanding all of the other codes under there. I think that might make more sense there.
Okay, that was P91.82?
Which
Okay.
doesn't have any codes yet. So maybe I think that makes sense rather than filling up your other.
Okay, we can take a look at that. Thank you.
you.
Are there any comments from the phone lines?
Hi, Erica, do you have another question?
I do. This is Dr. Erica Reamer. At the beginning where it says excludes to intracerebral, I think you said intracranial, and it looks like in I-10 it looks like it's supposed to be intracranial.
Okay. For the excludes to.
Yeah, it says intracerebral here, but I think it's supposed to be intracranial because that includes a whole bunch of other intracranial kinds of hemorrhages of the newborn.
All right, we'll make that correction. Thank you. Okay, not hearing any more comments. I'll move to the next proposal, which is found on page 62 in your topic packet, travel health counseling. This proposal is a representation. We presented this at the March 2018 CNM meeting. However, based on response and public comment, we're resubmitting a revised proposal for consideration. And this is at the request of the American Academy of Pediatrics, in which at that time they did request for new codes for travel counseling. It is of the opinion of the Academy that there are a variety of codes for counseling services. However, there's no unique ICD-10 code for health counseling related to travel. It is their opinion, again, that patients and caregivers often seek travel health counseling services and whom patients do not present with any other signs or symptoms, and the encounter may be unrelated to a preventive medical encounter. The Academy reports that there have been an increase in the number of patients that are seen for these services, and they are again requesting a specific new code to identify travel health-related encounters. So the proposed tabular modifications for subcategory Z71.8 of the specified counseling, where we are proposing a new code as Z71.84, encounter for health counseling related to travel, with an inclusion term of health risk and safety counseling for international travel. There are 2 excludes notice that's also being proposed. Excludes 2, encounter for administrative examination, which is the Z02. And encounter for other specified examination without complaint, suspected or reported diagnosis at Z01. Dr. Linzer.
This is something that we're seeing more and more now in the community physicians' offices, that the child is not being brought in specifically related to a well-child visit, but the family is planning on doing some traveling and wants to determine if they need additional vaccinations or what other risks they may be involved, whether they need to be started on prophylactic medications and stuff. So this is a unique encounter, and we have recommended that this code be added to be able to capture and track these type of specific encounters.
Thank you.
Lynn Keene Consulting. And to piggyback on Dr. Linzer's comment, I don't know, I'm questioning whether it might be helpful to have an excludes 2 that says Z23 for the immunizations.
Okay.
Because they may not need, you may not need to report extra for another exam, but it could be that they are going to have a series of immunizations to take that trip.
Thank you. Any other comments from the floor? Moderator, could you open up the phone lines, please?
If you have any questions at this time, please do so by using the raise hand feature. Your lines will be unmuted.
Are there any questions on the phone lines?
At this time, there are no questions on the phone line.
Thank you very much. My next proposal is found on page 33 of your topic package, and we will have a clinical presenter, but to give you a little background, this proposal was presented at the March 2018 CNM meeting. It is on Ehlers-Danlos syndrome. At that time, about 13 new codes were presented in recognition of the 13 different types of EDS. However, based on public comment, we stepped back, took a look at the codes that were proposed, and now revisions are being represented. Dr. Kay Jewell will give us an update on the clinical portion of this proposal. And Dr. Jewell, thank you.
Thank you. Thank you for this opportunity to come back and talk again about Ehlers-Danlos. I do have a disclosure. I am a consultant, and I am here on behalf of Acer, which is a drug manufacturer. They have Celaprolol, which is is recognized and used in Europe for the treatment of vascular EDS, and is being presented to the United States FDA for approval also. And then also I have to disclose that I am an advocate for EDS. My family has hypermobile, and my daughter is severely affected by it, and so I have to say I have a bias. So there. Is it this button? Which one? Which button is it?
This?
This one? Okay. So the expanded request is based on suggestions that we focus on the conditions, the types that have the highest in terms of life-threatening situations, the highest number, and those are the three that have been identified for this purpose. The first one is the vascular EDS. Vascular EDS prevalence is one. It's in your material, 1 to 50,000 up to 200,000. Its incidence is highest in the ages 18 to 34. The events are 25% of the events happen before the age of 20, and a number of those in males especially are sudden death. The average age for these events is ages 24 to 34. 80% of the people will have their events before the age of 40. However, many of them, 70% of them, will have their event before they pursue anything in terms of making the diagnosis. It's because the event at a young age triggers the thought that something else is going on here. The median age at death is 48. There's a little bit of a range in that, and the common cause is rupture. Aortic rupture is the most common at 79%. The organ ruptures include the spleen, the liver, and the heart for 10%, and then GI is 8%. 60% of the death by rupture is by the age of 40. The major criteria, the International Consortium on EDS in 2017 did a major revamp of the criteria for all of EDS, and that's where 13 types were identified. And the major criteria, as you can see, for vascular EDS are related to those causes of death: the arterial rupture, the spontaneous sigmoid perforation, uterine rupture, and then a small percent of them are the fistula in the absence of trauma. The mutation that's the COL3A1 mutation is one of the diagnostic criteria. This gene is responsible for the type 3 collagen, which is part of the vessels, the blood vessels, as well as the hollow organs, which explains the relationship to the different events that are part of the criteria. The minor criteria, there's 12. The most common are the ones on the left side, the first 6. The one that's also significant is the spontaneous pneumothorax. This is a common presentation in younger people, common in the sense of 10 to 20%. So oftentimes with the minor criteria, they're not thought, that's a retrospective thing. They have the major event, and then in retrospect, you look at them and you say, oh yeah, they have some of these other criteria. We can see how it all fits together. The minor criteria that are suggestive of it would be if there's a family history, if there's an arterial rupture or dissection in a person who's young, under 40, unexplained sigmoid colon rupture, or a spontaneous pneumothorax. And then the molecular basis, which is the presence of the gene mutation. It's clinically characterized by the aneurysms, dissections, and ruptures. In the vascular, it's more often the medium and large-sized arteries, and the rupture is not necessarily related to the size of the vessel. And the first complication, it's often the first complication that a person experiences in 50 to 60% at around the age of 25 to 32. Interesting, the GI complication or the rupture of the GI or the perforation happens in 21 to 30% at a younger age than the vascular complications, but it does represent 25% of the complications. And the uterine as a complication is often older, well, all of 28, older. But that doesn't mean that the women don't also already have other problems related to menstrual cycle and things like that. This is a picture, a distribution of 132 vascular complications that occurred in 24 patients. So you can imagine if there's 24 patients had 132 sites and complications, that each individual has a number of vessels that have been involved in the vascular EDS. Management is limited in many ways. The first is that if you have a suspected, that they begin the monitoring of the vascular system. It's often in the second decade of life, a non-invasive monitoring. Blood pressure management, currently, because of the experience with Marfan, where they learned that by using beta blockers, you could reduce the rate of some of the vascular events in Marfan, it's become part of the management for vascular EDS as well. And it's more in terms of the control of the pulse. This is where the issue of, in Europe, where there's a drug that's more specifically studied for vascular EDS, there's some difficulties in terms of the study, but it was stopped early because they thought that there was a positive effect. And then lifestyle adjustments, avoiding clinical, collision sports, anything that's kind of going to jar the system and potentially cause distortions of the vessels, which would lead to perforations and problems. And then a plan for emergency care, because it's important if a person is presenting with a rupture or a dissection, that whoever they present to knows what the possibilities are, because it has implications for the management. Even though aneurysm is listed as one of the possibilities, it's more often a dissection or a perforation or a rupture, and how it's managed will depend on where it occurs. If it occurs in a self-contained space, oftentimes now, instead of surgical management, there will be conservative management, monitoring it and hoping that it resolves itself safely. There's especially in emergent situations, there's a lot of difficulty, complications and mortality associated with surgery, and so it's best to wait if you can, if possible. That's why it's often the monitoring and identifying changes in like a vessel early so that it can be managed electively is much safer and wiser and has much better rates. If the surgery or an intervention is required, the two options are either open or endovascular, and the endovascular are usually an embolization, and it's more in like the visceral organs or the peripheral arteries or the fistula. Otherwise, if you're open procedure, the main goal is to do the least amount of disruption as possible. The open gives the advantage of better bleeding control because that's an issue, but they also want to do the least amount of damage because the tissues are fragile. And the complications that they experience are relatively high, up to 60% in some of the studies, and it has to relate to rebleeding, wound dehiscence, and then reperforation or dissection. In GI, the complication rates are also higher, not as high as in the vascular, but it's also an issue of reperforation. Many of the people in both vascular and GI end up with repeat procedures afterwards because the vessels are vulnerable. There is a study, there's some research activity that's going on now with vascular EDS. There's a registry that was started in 2015. The PCOR, the Patient-Centered Outcome Research Group, has funded a group, a collaborative, which includes patients as well as all surgical medical community, to look at what are some of the research priorities, and they've been holding meetings to discuss what will be the research priorities. The second area of talking about would be the hypermobile. This was one that there's a fair amount of concern in terms of how many people are going to be diagnosed or have been diagnosed with hypermobile EDS. It's considered, its prevalence is 1 in 5,000. It's the most common of EDS. It's considered the most common inherited connective tissue disorder as well. Under the old criteria, there's estimated there are about 10 million people who have hypermobile EDS. Under the new criteria, the expectation is that number will drop significantly. We don't usually give anecdotes. I'll give you one here. I have 3 generations in my family with EDS. I can tell you of the 17, probably 12 have the generalized hypermobility and a few skin issues, but we wouldn't meet criteria. We have 3 of the 17 who definitely meet the new criteria. So I'm guessing that that's going to be the experience as the new criteria are applied. It will require education to get the medical community as well as patients to understand the new criteria and apply them. So there's significantly more criteria. First, you still have to have the generalized hypermobility, but there's also a second criteria, which is actually more than 2 criteria. It's systemic manifestations, a positive family history who meets criteria, or musculoskeletal. In the past, all you needed was the hypermobility and 1 or 2, the skin issues. As you can see now, you have to have 5 of these 12, which are significant. Whoops. And or the family, if you have a family, a first-degree relative who has it, that would be a second, and then you would meet criteria 2. If you didn't have that criteria, you would have to have the musculoskeletal, which also is not just one single thing, but you have to meet it with a couple things. The musculoskeletal pain, the pain for 3 months, or the recurrent joint dislocations or frank instability, which has been documented and is more than one-time occurrence. And then a third criteria is you have to have exclusion of any other condition that could be accountable for this. There are other features that have been identified. However, when the consortium looked at all the literature, they didn't feel like the literature was strong enough in the research with the associations as hypermobile EDS was being looked at then for these other conditions. So that would be orthostatic instability or POTS, dysautonomia, functional GI disorders. In some numbers, 80% of people who have been diagnosed with hypermobile EDS have gastroparesis and problems associated with their GI tract. Fatigue, sleep, disturbance, anxiety, and depression. Anecdotal again, of the many people that I've worked with EDS, hypermobile EDS, those who meet criteria have a significant number of these other conditions, which actually is affecting their quality of life and their disability. So the rationale for having a specific HEDS is the highest number, and we also need to have stringent criteria to apply so we get people identified appropriately and we can start to look at the associations both to these other conditions in terms of causality, but also because of the genetic identification. This is the only one of the 13 that doesn't have a gene mutation associated with it. A big part of the reason is that if there are 10 million people, the pool is too big. It's too heterogeneous to identify the genes appropriately. And with Marfan, when they tightened up the criteria, they were able to zero in on the genetic picture. That's what the hope is with this new criteria for hypermobile. Classical, in some ways this looks like, oh, this looks like a lot like hypermobile. It's not. The skin hyperextensibility and atrophic scarring is much bigger as an issue for people with classical. It's much different, and it's, even though extensibility and all that is somewhat there for many, in this group of people it's much more significant, and the scarring is different and more significant. And then as well, the hypermobile joints. And then the minor criteria. The skin is really what stands out with the classical. This one is 1 in 20,000 prevalence. So in terms of management, the big issue is skin because that's the problem, a big problem here. Avoid undue trauma. Surgical concerns are also the bleeding, the tissue fragility, so that it impacts how the tissue is managed, how wounds are sutured, how things are managed. And then there's recurrence also because of that, as well as pain management. In both the generalized and the classical, pain management is an issue because of muscles and fatigue and also joint instability. There's a significant amount of pain that has to be dealt with. And then training, education about how to care for your joints, proper exercise, keeping active, and taking care of your joints, basically, is an important part. And then there's also how do you modify your life so that you don't cause yourself more damage. I think as I'm looking and I was sitting over there thinking about what we were talking about with what you all were talking about, like exclusions and things like that, I noticed under the other hypermobility, familial, and laxity codes, some of them specifically say excludes EDS, and there should be also an exclusion here in terms of excludes familial hypermobility, because that's the concern, is that they'll be inappropriately put in the wrong one. The other thing to consider, because of the differential for if you're first presenting with some of these aortic ruptures and vascular events, is if you're looking at genetic, is vascular EDS, Marfan, and Loeys-Dietz. They behave differently, they have different life expectancies, and they're managed a little bit differently. So it may also be of value in those conditions like ruptures, perforations, to also say that there should be a secondary coding if there's an underlying like vascular EDS or genetic condition, connective tissue condition associated with it, which will also help with analysis in terms of what's going on. Any questions? Okay.
Moderator, could you open up the phone lines, please, for any clinical questions? Moderator, could you open up the phone lines, please?
All phone lines are unmuted.
Are there any clinical questions on the phone lines? Okay. Not hearing any, I would like to present the coding proposal changes from the Q79.6. We are revising the code title of the subcategory Ehlers-Danlos syndromes. And as mentioned previously, we've gone from 13 codes to approximately 5. Q79.60, the Ehlers-Danlos syndrome unspecified. New code Q7961, classical Ehlers-Danlos syndrome with an inclusion term. classical EDS, similar pattern, Q7962 for the hypermobile, Q79.63, the vascular Ehlers-Danlos syndrome, and Q79.69, other Ehlers-Danlos syndrome. Again, this is more representative of, as Dr. Jewell indicated in her clinical presentation, of the most common and the most severe. So are there any questions regarding the proposed codes? Not seeing any on the floor. Moderator, could you open up for coding questions, please?
If you have any questions at this time, please do so by using the raise hand feature, and your lines will be unmuted.
Are there any coding questions on the phone lines?
At this time, there are no questions.
Thank you very much. And now I'll turn the podium back over to Shannon McConnell-Lanty. Thank you, Dr. Jewell.
Okay, the next topic is again in topic packet part 1, and it's on page 48. The topic is legal intervention, and today we have Dr. John Young from the Healthcare Quality Program at George Washington University School of Medicine and Health Sciences here to provide the background information for us. And I think he'll switch over to yes.
Okay, very good. Okay, great. Okay, thank you. Good morning. My name is John Young, and for full disclosure on the topic that I'm about to discuss, I'm not a law enforcement official. However, I did serve in the Marine Corps and am quite familiar with some of the terminology that I'll be using here today. I want to talk about, in this proposal, an emerging endemic that's happening across the country, and it's legal interventions that result in injury, and also updating the mechanisms of injury that we actually see being used. So by definition, a legal intervention is any injury sustained because of an encounter with any law enforcement official serving in any capacity at the time of the encounter, whether on duty or off duty, and includes injury to a law enforcement official, suspect, or bystander. So there are many definitions of legal intervention, but appropriately so, this is the one that ICD-10 has adopted. So here's the problem. The current ICD-10 CM legal intervention codes do not adequately capture contemporary mechanisms of injury used in modern day encounters between law enforcement officials and suspects and bystanders. And so the aim today is to add further specificity to legal intervention codes to reflect contemporary policing mechanisms of injury. I have some data, but I'm going to skip that part right now. But I want to ground you with some assumptions here first before I move forward. Any of the data that I'm presenting today represent patients treated in U.S. emergency departments. And this is a key point that I think is really important. Law enforcement officials, suspects, and bystanders may experience non-fatal injury during a legal intervention. So the key here is that although maybe suspects might encounter more injury, we have to be very clear that law enforcement actually experience such injuries as well during their duties, actually. A key point here also is that coding decision-making between emergency room clinicians and professional coders has not been taken into account here. But this is an important point because, as we all know, that key relationship between law enforcement and emergency department personnel is essential to correctly documenting a legal intervention or any sort of intervention, if you will, that happens within the emergency department. Injuries that result from legal intervention here are not considered, so I'm not really looking at the injury that actually occurred, but simply the mechanism of injury that was actually used during the legal intervention. And then finally, legal intervention is really a multi-dimensional phenomena. So to really capture the entirety of a legal intervention, multiple data sets are required to provide a comprehensive analysis of legal interventions that result in injury. So this slide right here is really essential. What I'm showing you here is the current coding scheme of Y35 codes and legal intervention. So here's sort of the pathway. A legal intervention occurs during a sort of a routine, maybe traffic stop or a stop on the street. It actually escalates into maybe a brawl or some other type of incident that involves injury. And the mechanism of injury could be one of these particular mechanisms that we have listed here. So if you look at the current coding scheme, Y35 is a firearm discharge. An injury can actually occur by an intentional or unintentional firearm discharge. Y35 is explosives. You don't see that quite often happening on the streets in the U.S., but this is actually something that does occur in the military. And just for full disclosure as well, there are Y35 codes or ICD-10 codes for military as well. But here we're talking about actually in law enforcement. Gas is another. Blunt objects include batons or any other inanimate object. Sharp objects as well. Interesting enough, in this one, you'll see bayonets or knives and so forth. But the important one here is the other specified means. And what's interesting here is that I've teased out Y3581, manhandling. This is interesting because there are actually there's a hierarchy of use of force, if you will. And in that hierarchy, manhandling is considered sort of a soft technique, meaning that when you manhandle someone doing a legal intervention, that essentially means pushing, maybe a shove, maybe a grab, or maybe saying simply sort of move along, let me sort of push you away. What's missing here are the more hard techniques. Hard techniques would include hand controls or takedowns that are solo or team takedowns, pressure points and firm grips, and most importantly, oftentimes, we see where law enforcement uses knees or fists or punches and hits. This is an emerging endemic that we're seeing. And so my hope is that, one, we can include more specificity that includes actually both manhandling, which is the soft technique, but also the hierarchy as we actually see in use of force that includes more of the hard techniques as well. And so if you look at what we have here now, if there were some type of brawl that happened or a police officer was hit via fist or a suspect was kneed, it's hard to code this. And I think the data actually plays this out. So I've been doing some research in terms of what's happening across states. And if we look across the United States real quick, there are about 2.2 million injuries across the United States. This was in 2016. And about 1.25 million of those were classified as other, meaning that there is no particular classification that they can attach this to, which is about 56% of other violence-related injuries are classified or misclassified as other. And then of that 1.25 million, about 3%, or about 75,000, were classified as a legal intervention, sort of all-cause legal intervention. But specifically on the ground in a state, and I took Maryland as an example, what's really striking about this particular slide is that although the count is relatively low in terms of the total number of legal interventions that occurred in the state at 54, if you look at those last three lines, 22% other specified means where the suspect was injured, 13% means unspecified where law enforcement was injured, 15% means unspecified where another suspect was injured. That's about 50% where a legal intervention occurred and an injury occurred, but the means was either unspecified or coded as other. So this is really important. And I think if we did a code-recode study, it would be difficult to go back and say, well, I can attribute most of these to the missing code of a physical force, if you will. I can't say that for sure, but I think it would be interesting to see where the codes would fall out if we did a code-recode analysis of the legal interventions that were coded either as other or unspecified. And so quickly here, some of the literature, some of the trends that we're seeing in the literature suggest this, and I won't read all these to you, but I think there are some important points to take away, is that legal interventions are on the rise. In the District of Columbia, for instance, in FY17, there were 2,200 legal interventions, of which only 10%, I'm sorry, take that back, 10, a count of 10, were actually the result of the mechanism by firearm. Just 10 of those 2,200. However, over 36% actually were sort of unspecified, and actually from year over year, we're seeing an increase of over 30% in the district of legal interventions that actually occur. And this is probably the most important point here, is that there needs to be better data collection and population-based data on the physical and mental impairments that result from a legal intervention and the long-term disabilities that we see as well. So in the current coding scheme we have right now, the mechanism of injury that actually affects a suspect, a law enforcement official, a bystander, and the sequela, which is actually the long-term effects, of which I think as a researcher it's really important to understand the longer-term effects of this particular phenomenon as well. And then also there's evidence that maybe emergency department physicians really don't know how to handle these cases in terms of coding, and actually sort of the shared decision that might occur between an emergency department physician and a coder to actually document a legal intervention that resulted in injury via physical force or some other type of mechanism, and making sure that it's correct and doesn't need to be recoded or it's misclassified in the medical record. So this is really important. I think there are some trends that are occurring. And finally, technology and police injuries related to conductive energy devices, or CEDs, is another thing that's emerging in the literature as well. And essentially going back to the Maryland data, if there were an injury by a CED, or an ECD rather, where would I code this? I would have to put it into unspecified, which again, it really doesn't collect the data with precision as ICD-10 was intended. So in closing, the proposal is to add new Y35 subcategories to the mechanisms of injury to the other specified means. Number one is to add bodily force, which is, again, along that pathway of the degree of, or the hierarchy, if you will, of use of force. So from manhandling all the way through bodily force and other mechanisms. And then also add conductive energy device, or CED, which is also a taser. So the importance of this is that the results can potentially lead to a reduction in the misclassification of legal interventions that result in injury. There'll be better data for public information. And as well, there's more focused law enforcement training, as well as focused community-based interventions. And more importantly as well, again, we can collect the mortality data for a legal intervention that results in death, but it's much more onerous, if you will, to collect data around the, the morbidity data we can collect with the the mortality data we can collect with morbidity is really important as well. Those are the injuries that, those non-fatal injuries that we just have a problem collecting right now. And then finally, improved documentation of the origin of the injury. It might manifest in long-term physical, mental, or social injury, but if we can't document that with better precision, it will be much more difficult to understand the origin of injury. Thank you.
Thank you. Are there any questions or comments for Dr. Young before we go over the tabular modifications here in the auditorium? Okay, I'm going to go ahead and go through the tabular modifications before I open up the minds. Thank you. Okay, so the proposed tabular modifications are at category Y35, legal intervention, to create a new subcategory with the codes Y35.82, legal intervention involving bodily force, with the following new codes: Y35.821 for legal intervention involving bodily force, law enforcement officer injured; code Y35.822, legal intervention involving bodily force bystander injured, and Code Y35.823, legal intervention involving bodily force suspect injured, and to create a new subcategory Y35.83 for legal intervention involving a conducted energy device with two inclusion terms, electroshock device, taser, and stun gun. Following new codes would follow there under that subsection. Y35.831 for the legal intervention involving conducted energy device officer injured. Code Y35.832 for bystander injured, and Y35.833 for suspect injured. Are there any comments or questions here in the auditorium?
Sue Bowman with the American Health Information Management Association. I guess one question I have is, I know part of the point of this is to distinguish between manhandling and bodily force, but how would a coder make that distinction, and how would that distinction, be documented so that these codes wouldn't sort of be muddied up together?
Great question. Actually, the distinction is made between the law enforcement officer speaking with the emergency room department physician or clinician. So that, as we know, relationship is very important anytime there's a legal intervention that occurs. So that conversation is documented in the notes, and then from there, from the notes, the coder then is able to should be able to code that a legal intervention occurred where an injury actually happened and the mechanism of injury was physical force, or mechanism of injury was manhandling. So that conversation comes from the notes. But again, what's happening now is that the evidence might suggest that the relationship or conversations that occur between a law enforcement official and an emergency room clinician doesn't really happen at that level because the code can't sort of adequately reflect that, and for various other reasons as well. That's a study in and of itself, but the code isn't available in the event that that discussion is documented appropriately.
Dr. Lindsay?
Jeff Linzer speaking as an individual. As an emergency physician, that conversation generally is very brief in my experience, and doing compliance reviews, if the physician is not using a checkbox EHR, they may say that the person was injured in a struggle, if that. Sometimes you may see that they say they were tased. So while I appreciate where you're trying to go with this, knowing how our colleagues document or don't document, I could see where a coder could have a problem if all that was documented was patient was injured in a struggle.
Okay. Moderator, could you please open the lines for any questions or comments?
If there is any questions or comments at this time, please do so by using the raise hand feature, and your lines will be unmuted individually. Hi, Teresa. Do you have a question?
Yes, this is Teresa Rahanek, IMO again. I kind of echo Sue and Dr. Linzer's comments that it is difficult for a coder. The documentation isn't necessarily there to distinguish between manhandling and bodily force. If we do incorporate these codes, I think there needs to be an includes note to help the coder distinguish what manhandling means versus bodily force, because I think that it's kind of confusing. You grab somebody, I don't know, is that bodily force versus the manhandling code? So that's kind of confusing. So some includes notes to identify for the coder's use later on would be helpful.
I fully agree with that. And as far as the current codes are considered, manhandling is there. And if there's a definition that exists, then it will essentially parallel what law enforcement defines as manhandling, which again is pushing and shoving. And I had this conversation the other day. Manhandling is use of force to some degree, but it's in the hierarchy, it's really at the bottom. Use of force could be handcuffing. That's at the bottom. I can take it to the very extreme where use of force is actually pointing a weapon or being shot and injured with the weapon. There are many things that happen in between. This is being coded and documented. However, the phenomena of physical force doesn't exist, nor does current electronic devices, which are used in law enforcement, doesn't exist as well. And I don't think it does us from a public health perspective or from a clinical perspective any good, or even a law enforcement perspective, not to accurately identify the source or origin of injury, especially if physical force is used at the higher end or somewhere in between, such as, again, the more hard techniques, or where the taser is used. So these are the things that are happening, the current phenomena that's emerging, if you will. And so I agree with you 100% that definitions, one, have to be available, but two, I think even in partnership with law enforcement across our communities, we have to strengthen that relationship so that we're talking the same language.
Are there any additional questions or comments on the line?
No additional questions.
Thank you. So we will move on to the next topic. Thank you, Dr. Young. The next topic can be found on page 50. And the topic is legal intervention involving injury of unspecified person. The Massachusetts Injury Surveillance Program within the Massachusetts Department of Public Health is requesting new ICD-10 CM codes related to injuries resulting from legal intervention. The current ICD-10 CM has the Y35 codes. However, they are requesting codes to capture when there is no documentation of bystander versus the officer, so for that unspecified person. As well, they are requesting additional new code for legal intervention involving conducted energy device, including tasers. So the proposed tabular modifications are at category Y35, legal intervention, at subcategory Y35.0, legal intervention involving firearm, at the subcategory Y35.00, legal intervention involving unspecified firearm, to create a new code, Y35.009, for legal intervention involving unspecified firearm, unspecified person injured, and creating a similar code for unspecified person injured at the Y35.01 subcategory for legal intervention involving injury by machine gun. Repeating that same similar code at Y35.02 for legal intervention involving injury of handgun. At Y35.03 for legal intervention involving injury by rifle pellet. At Y35.04 for legal intervention involving injury by rubber bullet. Also at Y35.09, legal intervention involving other firearm. With a similar pattern, also at subcategory Y35.1, legal intervention involving explosives. And at subcategory Y35.2, legal intervention involving gas. At subcategory Y35.3, legal intervention involving blunt objects. At subcategory Y35.4, legal intervention involving sharp objects. Also at subcategory Y35.8, legal intervention involving other specified means, and also to create a new subcategory Y35.83 for legal intervention involving a conducted energy device, with the inclusion terms electroshock device, taser, and stun gun. The following new codes: Y35.831 for the legal intervention involving a conductive energy device law enforcement officer injured, .832 for the bystander injured, Y35.833 for the suspect injured, and Y35.839 for unspecified person injured. Also, a new code under Y39.9, legal intervention, means unspecified, again to capture the unspecified person injured. Are there any questions or comments here in the auditorium?
Lynn Keene, Keene Consulting. Is there an intentional reason why we didn't carry through Y3582 for the bodily harm addition that we wanted in the previous proposal?
No, that should definitely be included as well for that unspecified person. Thank you so much.
Sure.
Any additional comments, questions? Moderator, could you please open the lines for any comments or questions?
If you have any questions at this time, please use the raise hand feature and your lines will be unmuted individually. Hi, Erica, do you have a question? Hi, Erica, do you have a question?
Okay, I thought we may have a question. Moderator, was there no response?
There was no response.
Okay, thank you. So hearing no additional comments on the phone, I am going to move on to the next topic. And if I could please ask if Dr. Ian Miller is in the auditorium? Oh, great. Okay, great. So the next topic is again in topic packet part 1 on page 32, and the topic is Dravet syndrome. Dr. Miller is the medical director of the Comprehensive Epilepsy Program at Nicholas Hospital, and he is here to provide the background information. This is a proposal that was previously presented at the March 2018 Coordination and Maintenance meeting, and he will provide again the background information for those that did not receive it earlier.
So a lot of this is similar to what we discussed in March. In terms of disclosures, I have had sponsored research and travel from 3 entities which are doing research and coming up with treatments in Dravet syndrome. I'd like to discuss briefly the clinical signs and symptoms in Dravet and what makes it unique. I'd like to emphasize the fact that it is a very clearly defined syndrome. One of its notable features is the fact that it starts early. 95% of kids have onset before age 12 months. It is characterized by seizures that are hemiconvulsive and quite long, often 30 minutes or longer. Over time, the children develop to have other forms of seizures also, which include both generalized and focal seizures. They do have both, but generalized tends to be a little bit more prominent early on. The seizures are often provoked by fever, including vaccination. So for any general pediatricians in the audience, if you come across somebody that looks like they've had a vaccination-induced form of epilepsy or vaccination-induced autism, Dravet syndrome is definitely something to consider. But these seizures can also be provoked by other forms of extreme temperature change, such as coming out of a hot bath or getting out of a pool. And they have the appearance of epileptic regression, and it gives you the appearance that the seizures are causing this autism or developmental impairment because the learning is normal to start and becomes abnormal. And autism is a very heterogeneous thing, as is epilepsy, but Dravet syndrome is one specific cause of both autism and epilepsy. And unfortunately, Dravet syndrome is very highly resistant to medication. This picture in totality is so characteristic that it's very straightforward for my secretary to diagnose these patients when they come in. Once she hears a few of these features, it's relatively straightforward, and I think there's unanimous agreement among child neurologists who these kids are. So to kind of fill out the clinical picture, it does have unique complications and treatment implications. Seizures become worse with specific medications, which is why it's so critical to have specific ICD-10 codes here, because if that ICD-10 code is on the chart, it will flag the fact that you should avoid things like carbamazepine or oxcarbazepine or phenytoin. It also affects other organ systems and has other manifestations that other forms of epilepsy don't, which includes gait and posture, which means the kids need physical therapy and occupational therapy, which might not be appropriate from a utilization standpoint for other forms of epilepsy. It has a very high risk of sudden death, which is called SUDEP. The lifetime risk is probably on the order of about 15%, and as a result, these kids need cardiology screening, which again, if you don't have a specific code, looks like an inappropriate utilization when you're reviewing the chart later. And unfortunately, the condition is fairly common. Estimates are between 1 in 15,700 to 1 in 20,000, and that information is based on WU in 2015, which has a very, very concrete denominator, which is the hard part of epidemiological studies to pin down. So I think that number is very reliable and very real. Importantly, there are clinical trials going on right now that have looked at treatment of Dravet syndrome, and this is one of the reasons why we need a specific ICD-10 code if, well, these medications are coming to market. CBD, which is cannabidiol, which is one of the forms of medical marijuana, was approved by the FDA in June this year. It will be rescheduled by the DEA, hopefully sometime this week. Actually, their deadline was 90 days, and that's coming right up. So once that happens, it will be available for prescription, and the indication for that is both Dravet syndrome and Lennox-Gastaut syndrome. If we don't have an ICD-10 code for Dravet syndrome, it becomes extremely challenging for individuals to know whether or not these medications are FDA approved or not. So the companies that are coming up with these treatments include Zogenix, Greenwich Biosciences, Insys Therapeutics, and others that are on the way but farther away from clinical use. In terms of indicated medications, there are 2 medications that have been approved by the FDA as of now, the cannabidiol, which is the one that I mentioned, but also stiripentol, which is a medication that's been around for a long time, used in Europe, and until this year wasn't approved by the FDA, but is now and is not yet available for prescription, but will be in the next couple months. And there are more coming. Several others have been on the track to be approved when and if their pivotal trials pan out because of the orphan drug designation that gives Dravet syndrome kind of special market exclusivity when it's approved for that condition. So current codes are not specific enough. We can't specify the clinical syndrome or package of all these things that we mentioned. We can't capture the multi-system effects of Dravet, which leads to confusing and inconsistent records. It leads to multiple and inconsistent codes, which kind of amount to the fundamentally the same thing. And it introduces friction into clinical care and research studies, which we all want to avoid. And as a result of this confusion, it directly affects patient care and harms the kids that have this condition, which is bad enough by itself, even when the system is working the way we want it to. I do want to highlight the fact that the carbamazepine, oxcarbazepine, lamotrigine, and phenytoin should be avoided in these kids, and short of an ICD-10 code that's specific, we can't automatically have the computerized medical record work for us by flagging these as being inappropriate. And if there's no ICD-10 code, we get errors, lack of appropriate treatment, and inability to track mortality. We talked about the mortality rate of being 15% due to SUDEP. In total, it's 17 to 20% by adulthood, and we can't track that without the ICD-10 code. We also can't look at things like utilization or outcomes with our cardiology colleagues. Right now we have very few treatments that will actually address or lower this mortality, and it's possible that we might, but that improvement is slowed down by the fact that we can't track these kids carefully. Having ICD-10 code, we think, will improve clinical care because fewer patients will be placed on contraindicated medications. 49% of patients take lamotrigine, 39% of patients take carbamazepine, and 36% of patients take oxcarbazepine in terms of having been exposed to it. And this is inappropriate, so those numbers are shocking. You'd think that the rate would be much lower, and the fact that you don't have an ICD-10 code is kind of incidental, but in reality, it's actually very, very common. The ability to track outcomes of clinical interventions is important as well. 3 clinical trials have been completed and or are underway in the past 2 years, all orphan drugs with the DS indication. And the development of protocols for standardization of care is also affected by the lack of an ICD-10 code. So it will help us improve things in affecting cardiac involvement, getting speech therapy, physical therapy, occupational therapy. It will help us address the sleep comorbidities that come along with this, the orthopedic comorbidities that come along with it, as well as GI, developmental, behavioral, and autistic symptoms. It will allow us to understand the drivers of severity, risk, different symptoms, and comorbidities. The list here includes size and weight, language abilities, and seizures, which we haven't really included in the list in the prior slides. And in summary, the key part about this is really having specificity and capturing the total meaning of Dravet syndrome. The other forms of epilepsy, which are less specific, have been approved with an ICD-10 code, and this seems to us to be a natural extension and to kind of be meeting the same bar or the same threshold for other forms of epilepsy, which already have a specific code. Without the code, the harms to the patients include inability to automatically flag prescriptions which are contraindicated, inabilities to determine the qualification for novel therapies, the failure to alert for cardiac screening for SUDEP, the failure to alert or authorize gait-related therapies, and the failure to alert families about the recurrence risk because it is a genetic syndrome. Thank you.
Are there any questions for Dr. Miller?
Jeff Linzer, AAP. We support the revised proposal, but I have a question. In the initial part of your presentation, did you refer to post-vaccination autism?
Correct.
And are you saying that there is such a condition?
I have 150 patients who have developed seizures and autism after vaccination, and it's not the vaccination that caused it, it's a gene that caused it. So these are the kids for whom lay people understandably say, oh my gosh, there's a connection between vaccination and seizures. In fact, there's not. It's a genetically mediated and genetically determined disease. And rather than understanding the condition, we didn't understand the condition before we had the genetics for it, but we spent a lot of money trying to understand it, and now we finally can.
Yeah, no, I appreciate the clarity of that it's a genetic condition and not due to the vaccine. I just want to make sure that that's clarified.
Yeah. Any other questions?
Okay, no other comments or questions here in the auditorium. We will go ahead and take a look at the tabular modifications. Okay, so the proposed tabular modifications are at category G40, epilepsy, to create a new subcategory, G40.83, for Dravet syndrome with 3 new codes, G40.831 for Dravet syndrome intractable with status epilepticus, G40.832, Dravet syndrome intractable without status epilepticus, new code G40.839, Dravet syndrome unspecified, with the following inclusion terms for the polymorphic epilepsy in infancy, severe myoclonic epilepsy in infancy, and Dravet syndrome NOS. Are there any comments or questions on the coding portion? Okay, moderator, could you please open the lines for any comments or questions?
If you have any questions at this time, please do so by using the raise hand feature, and your lines will be unmuted individually. We do have a couple questions here. We'll start with Luana. Do you have a question?
Hi, yep, this is Luana Ciccarelli. I'm a staff with the American Academy of Neurology, and the AAN supports the addition of the code and think this is a good proposal. The one comment that our clinical advisors had was they were unsure if there was a need to add the G40.839. They stated that those terms, the PMEI and SMEI, are older names for Dravet syndrome and could potentially be added as synonyms under the Dravet syndrome heading. But otherwise, we support the proposal.
Thank you, Luana. From AAN, were there any additional comments or questions on the line?
Hi, Erica. Do you have a question?
I'm sorry, were there questions or no further questions?
There are questions. Okay. Erica, do you have a question? Okay, we'll move right along. Teresa, we'll go ahead and answer your question. Go ahead.
Hi, Teresa Rahanek from IMO. I also want to echo that I do not think that G40.839 is necessary. For the information, this condition is only intractable, and historically, if we don't have information about status, it defaults to the without status epilepticus in all of the other codes. So I think G40.839 doesn't need to be added. And also a question if the index will be modified for that severe myoclonic epilepsy in infancy. If you do epilepsy myoclonic, it takes you to C generalized. So I think maybe we need another subterm there to correct for the infancy to this new code.
Okay, thank you.
Thank you.
Moderator, were there any additional comments or questions?
At this time, there are no additional questions.
Okay, great. Okay, at this time, I'm going to go over the next topic, which is on page 55. The topic is osteopenia of the hip. Osteopenia is diagnosed using measures of bone mineral density. There is currently no unique code for reporting osteopenia of the hip, and the submitter, this is a submitter requesting the following tabular modifications in order to capture this condition. And AAOS has reviewed and they do support this proposal. The proposed tabular modifications are at category M85 for other disorders of bone density and structure, at subcategory M85.8, other specified disorders of bone density and structure, to create a new subcategory M85.8A for other specified disorders of bone density and structure, hip, and to add the inclusion term osteopenia of hip with the following new codes: M85.8A1 for right hip, M85.8A2 for the left hip, and M85.8A9 for unspecified hip. Are there any comments or questions here in the auditorium?
This is Sue Bowman with the American Health Information Management Association. I guess I'm just wondering why it wasn't proposed to have specific codes for osteopenia. That's a commonly diagnosed condition. So rather than just making an inclusion term, it seems like it would be more helpful and useful to have specific codes that state osteopenia.
Okay, thank you. Good morning. Are there any other comments or questions here in the auditorium? Okay, moderator, could you please open the lines for any comments or questions?
If you have any questions at this time, please do so by using the raise hand feature, and your lines will be unmuted individually.
Okay. Okay, hearing no other questions or comments from the phone lines, I am going to turn the podium over to Donna Pickett.
Okay, just give us a few minutes for transition. David's going to pull up the next set of slides. For a bit of a change of pace, I know many of you have had questions related to ICD-10, particularly since the WHO announced the launch on June 18th. And so for informational purposes, we wanted to bring a presentation to you. Some of you may have heard part of the presentation previously, as the National Committee on Vital and Health Statistics has actually been having sessions related to the release of ICD-11, most recently in July. So we've been doing presentations there, but we realized that we While many of you do know, there are many who don't know, so we wanted to bring some information forward. And apologies to all of you who have heard this before. Okay, the first slide, very quickly, is just, and some of you have seen this before, what we've done is updated it. This is a history of the process of ICD-11 and its ICD in general and its revision process. And as you can see from the early years, it started in 1900, fast forward to ICD-10. Now, ICD-10, the WHO version, was implemented in the U.S. for mortality coding, that's specifically death certificates. And of course, all of you are very familiar that ICD-10-CM was implemented October 1 of 2015. It took a little bit of time to get that done. And so on the last line, I have ICD-11 listed there. Interestingly, though there has been a launch by WHO, the version that is currently posted is a version that is implementation ready. And basically what that does is it gives countries and regions who would be implementing ICD-10 an opportunity to take a look at the content, the new features, et cetera, in order to start preparing for the transition. The actual approval date by the World Health Assembly does not occur until May of 2019. And more about that date as I go through the presentation. And I'll apologize in advance for my voice. Now, these slides are going to look very familiar. Why? Because again, when updating or going to a new version, there's a lot of work that is involved, but it's all very similar work. So what WHO has done was to do a scan of the landscape to see what issues needed to be addressed if there were to be an ICD-11 compared to ICD-10. Now, again, for ICD-10-CM, again, we just implemented October 1 of 2015. Many countries, however, implemented ICD-10 for mortality and for morbidity applications much earlier. So while this sounds kind of surprising to U.S. for morbidity purposes, countries have been using ICD-10 since 1996 and forward. So we were the last to implement for morbidity, but other countries have been using it for quite a bit of time. And even though there was an update process for ICD-10, that process really could not accommodate many of the changes that was being seen in healthcare. Now, these are the WHO uses for mortality statistics and a number of other purposes, and also to meet the WHO Sustainable Goals development. And in that list, you'll see NDC, that is not national coverage determinations, that is non-communicable diseases. So I had someone ask me, well, why are they looking at coverage? They're not, and it's something that obviously WHO does not address as part of their updating process. They also obviously use it for morbidity purpose, now more than they did originally when the ICD was first created. Basically, the original ICD and most revisions up until about ICD 8 or 9 focused on mortality. But it's become quite obvious to everyone that ICD is being used for a variety of purposes well beyond mortality statistics. And again, some of these things you'll understand because we've had those discussions as we had testimony and other hearings and such, preparing for the transition from 9CM to 10CM. Administrative tools, again, these are more morbidity related, but again, these were more recent activities and issues being where ICD is being used. So getting back to ICD-10, and to kind of pick up on what I was just indicating, ICD-10 was approved by the World Health Assembly in 1989. The tabular list, and again, we're talking about a manually curated world. We're not talking about an electronic environment. So the tabular list for ICD-10 was released in 1992. The index was not made available until 1994. So countries really couldn't even start the implementation process because you needed both pieces in order to figure out what to do and how to update your systems. And again, for mortality in the U.S., ICD-10 was implemented in 1999. WHO did have an updating process for ICD-10, which was a first. ICD-9 did not have an updating process. And in fact, prior to ICD-10, when a version of ICD was published, it was held whole until the next complete revision. There was no update process, which also helps us understand why for ICD-9, the U.S. developed a clinical modification that did have an updating process so that things were not held stagnant for 10 or more years. ICD-10 was published in 43 languages. It's used in over 100 countries with about 24 modifications. For ICD-10-CM, the U.S. is not the only country that has a national modification. National modifications do exist in countries such as Germany, France, Canada, Australia. Some countries have actually adopted another country's modification. So you do have other countries using the Australian modification, ICD-10-AM. And again, looking at everything that each of these individual countries did in their national modifications also gave a lot of focus to WHO on the kinds of modifications that might need to occur with the next major revision. So again, ICD-10 is now more than 25 years old, but of course ICD-9-CM was also more than 25 years old, as we well remember, because that was implemented in 1979. I'm not going to read the entire slide. We will be posting these slides. But again, there was a need for ICD-11 to catch up on all the substantial advancements in medical science and in knowledge, looking at something that was no longer manually curated, that was updated electronically, developed electronically. The need to capture more information, again, for more specifically morbidity purposes. The work began in 2007. And so here's the list of all the issues that were kind of the focus for starting the ICD-11 process. And the goals, very important here. One of the important goals, not just to capture changes in medical knowledge and science, but also to link with terminology such as SNOMED, and also to look at how to develop something that could be easily taken up into electronic health records and information systems. And again, multi-purpose, but with a much more heavier focus on morbidity and other use cases for the classification. And better integration with, again, terminologies and classifications. And the revision process is explained here. It's a much more expanded process. Some of you in the audience have actually been involved in parts of it previously. This is the largest revision that WHO has undertaken as it relates to the ICD. They developed a platform so that everything wasn't being shared via emails and snail mail, et cetera. There was an electronic platform where you can actually go in, put in a proposal. You can actually make comment on content that is currently part of the ICD-11 that was released in June. Hundreds of scientists and clinicians from all over the world participated in the process, and more than 90 countries have been involved. This just shows you some of the working processes that were developed. WHO set up topic advisory groups. There were many of them, and some of them had actually working groups under them. Notably, there was a pediatric tag that was actually chaired by someone from the U.S. Dr. Linzer, thank you for all the hard work that you did with that. And we did have a lot of U.S. involvement in the development of ICD-11. But again, we weren't the only voice in the room. Many countries, and many countries with experience in developing their own national modifications, participated. But we also had countries participating that represent those who are solely using the ICD for mortality purposes only. And under that umbrella, we also had a revision steering group. There was a small executive group for the steering group, and now we have a task force that basically, now that the topic advisory groups have been sunsetted, that continues the work and to look across all use cases, morbidity, mortality, functioning, case mix, to see where the similarities were, what were the key points, and what were the things that need to be taken up and considered as part of the ICD-11 revision process. So there were 30 topic advisory groups and working groups. And so what's new? And again, without these slides, you can go to the WHO website. They do have pages set up so that you can actually look at ICD-11, look at the members of the different working groups and tags. So there is a lot of information on the website, which again is a huge difference from when ICD-10 was released. There is new content, and I'll be covering some of that in a little more detail. But they also, again, had a very keen eye toward the world of digital and electronic. So there are coding tools that have been developed to go along with ICD-11. There's browsing tools, mapping tools. So there's a lot more support for the classification than there was when ICD-10 was released, because basically what you had for ICD-10 was the index, the tabular list, and the instruction manual, with no electronic support at all. So again, big changes, which also imply big challenges in terms of how that all gets used together. And again, the process started in 2007, and they had an external review in 2015. 4 phases, and there's a lot of information on the WHO website regarding the 4 phases. So there is a foundation layer. So, you're not just opening up the tabular and saying, okay, we need to put detail here, we need to put detail there. There was a foundation beneath all of the work that rose up to become the classification that you will now see on the WHO website. And there are components where you're looking at the content, what makes up the diagnosis, what are the standard practices related to these things. And they're basically definitional. They are not, or description-based, not definitional. So it's to help you understand what is in the classification, what components were considered, what components may not have been considered. And you'll also see what are descriptions in the base of the classification, which basically tell you, as a user, what is in this category. So you're not having to try to figure it out on your own, or you have people coming with different perspectives, thinking that, well, this is based on this, and maybe it's not. And as all of you who have participated in this process understand, depending on the specialty, you have differences of opinion as to what something means. So what WHO has done is put in descriptions to help you understand what they mean by what they placed in the classification. There's multiple parenting, so in the base of the classification, you can have a concept that maybe is described as related to neurology, but it may have a concept that is also related to another chapter. So it's multi-parented, but in a classification, they select one key factor, and that is what determines where something is placed in the classification. And so we have the ICD-11 for morbidity and mortality statistics, again, making clear that morbidity is actually a key factor in the development of ICD-11. And everything is derived from the foundation layer, and that there is structural consistency with ICD-10 where possible and where science hasn't changed, so that you are still able to trend based on everything that you had collected over the last 25 so years in ICD-10, primarily again for mortality, that it is consistent with ICD-11. And that was a key concept that users really wanted to keep in mind. They just didn't want you to throw everything out and start over. Examples from WHO of problems that have been solved with ICD-11. That was, anything related to antimicrobial resistance was basically missing from ICD-10. However, we did have things in ICD-10 CM that we had added, and those things were looked at by WHO. The HIV subdivisions in ICD-10 woefully outdated, so that has been updated in ICD-11. Simplified way of doing diabetes coding. A problem there was right after ICD-10 was published, there was a new WHO consensus on diabetes and how to classify it that never made its way into ICD-10. And so what happened was you had all those countries with national modifications. We also kind of developed with the experts in a given country how diabetes should be characterized. And so for every national modification, you had a different way of representing diabetes. Clearly, when you're trying to do international comparability and trending, that's a disaster. So WHO has dealt with that in ICD-11. Skin cancer, melanoma types were missing in 10. That has now been incorporated into ICD-11. Valve diseases, the coding of post-procedural conditions, and some of the issues that have been raised through the ICD-10 CM process about, why are some things in the complication chapters and other things are in the body system chapter. WHO also took that on board because I think the U.S. clinical modification was one of the first countries to try to deal with that, as did Canada and Australia. So again, WHO took that on board to try to come up with a standardized way of representing these things in ICD-11. So the codes will look different. I will show you examples of that. And there are some simplifications that have been added to ICD-11 that I will talk about that may pose challenges for countries when they look to implement ICD-11. Some new concepts like extension codes. In 10CM in other countries as well, but developed their own clinical modifications, we created a lot of pre-coordinated codes. The concept of this and adding either laterality or severity or acuity was handled differently, but we did it with pre-coordinated terms. What WHO has done to simplify the classification is to create a chapter that has nothing but extension codes. So if you want additional detail, you will be using additional codes separate from the main codes to describe acuity, topography, anatomy, laterality, and clustering, which is a way of combining the codes so that you can see the relationship of diabetes and a separate code for manifestation, which is what we currently do. It will be a cluster code so that you can see it as a string and know that those two concepts are related. Some diseases have changed location. Again, no surprise there, but that also happened with the transition between 9 and 10. There are 6 new chapters, diseases for blood and blood-forming organs, immune system, conditions related to sexual health, sleep-wake disorders, again, the new chapter for extension codes, and there is a new chapter for traditional medicine. not the procedure side of traditional medicine, like doing the acupuncture, but actually the traditional medicine diagnoses. WHO has intended to make this IT-friendly, so there are web services, online services, output files, and print versions that can be derived from the files that they've posted. The implementation package that WHO has developed includes a number of materials, advocacy materials, training materials. Again, these are all focused on the WHO ICD-11. It is too early to tell whether or not any country, including the U.S., will need a national modification. But again, training materials for base ICD-11 are available. Mappings are available, which was something that didn't happen when they moved from ICD-9 to ICD-10. Training and test platforms. So again, a number of new features, all designed to facilitate the implementation of ICD-11, and so that no one had to start from scratch. And then also start from scratch and perhaps do it differently, which again goes, takes you away from standardization. The process for agreeing and adopting, again, a stepwise working process. I won't go through all of it, but you'll have it in the handout. And the various steps of piloting. And some of you were aware that WHO was actually piloting and had contacted us, but I'm sure that at the point that we start talking about implementation of 11 in the U.S., possibly, there will be pilots. So, the opportunity is not lost. So the launch, as I indicated earlier, was June 18th. And the materials for the launch are on the website, as is the press release and some other related things. So I'll start with mortality. That's a lot easier to deal with, I hope. Because there are two implementation pathways in the U.S. Obviously, we have one for morbidity, which you all know and love, and then there is a pathway for the mortality side. And so for mortality, it's a revision of all of their automated coding systems and decision tables, a retraining of the nosologist and medical coders that deal specifically with death certificates, computer edits, revisions of the tabulation list that they use to report out underlying cause of death, comparability coding, and the development of educational and promotional materials. Implementation of ICD-11 in this particular instance is not covered under HIPAA. So it is a U.S. decision on the timing and when to move forward and how, but it is not handled through rulemaking. It doesn't mean it makes it easier, but it also doesn't mean it makes it harder. They just have different steps to go through. And of course, the key for each is making sure there are available resources to do all of the work. For mortality, as noted by my mortality colleagues, it took the U.S. 7 years to implement ICD-10. And again, that was without all of the electronic support that ICD-11 is supposed to bring to bear. And as mentioned, sufficient resources in terms of personnel and changes in IT systems is at the heart of the timing for when mortality would be able to move to ICD-11. Right now, they're looking at, for mortality, a minimum of 5 years, but no sooner than 2023. So again, this is not overnight, and they're not dealing with a regulatory process. Okay, so the fun one is morbidity. And no surprise, or it shouldn't be a surprise, rulemaking will be in play for any discussions related to transitioning to ICD-11 or possibly a national modification of ICD-11. Interestingly, though, there are some issues that were present when the U.S. was looking at transitioning from 9 to 10, and one of those things is licensing implications. As you all know, ICD-9 CM had no license requirements. But also WHO did not have any licensing requirements for ICD-9, upon which 9CM was based. For ICD-10, WHO did have licensing requirements. However, the use in the U.S. Basically took us back to no licensing restrictions. However, because of such an abundance of national modifications, WHO really would like to see those licensing limitations put in place so that they can maintain control of their ICD classification. So there may be implications in terms of the agreement between the U.S. and WHO and other countries that had national modifications in terms of what they can and can't do if considering moving to ICD-11. And for implications here in the U.S., I just list a few. What does that mean for vendors? If there is a licensing requirement, are you going to be needing a license to publish a code book? Are you going to be needing a license to incorporate ICD-11 into your data systems? A whole host of questions that we did not have to deal with in looking at the transition from 9CM to 10CM. And those kinds of issues will be something that will be discussed as part of the National Committee on Vital Health Statistics role in calling for hearings in the future related to transitioning to ICD-11. And WHO, again, would like to limit the number of national modifications, but those discussions have not even begun yet. But I think now that there is an implementation-ready version of the ICD available, and the fact that the World Health Assembly will be adopting next year, there will be opportunity for those discussions to occur in each country. And then, of course, there's the issue of, will the new format, how will that fit into electronic data exchange, using the 837s? How will that affect the paper forms, the UB04, the 1500? A lot of implications here in terms of how much prep work is actually needed before you can even begin to think about how do you implement something. So changes in chapter number. I'm speeding up because I want to make sure I don't stand between you and lunch. Again, you will have the PowerPoint presentations, and if necessary, we can revisit the topic at a future meeting. So there are changes in the numbering system, the coding scheme. This slide does have examples. You may not be able to read it on the screen, but they're there for you. But the extension codes, I know, has raised a few eyebrows about, well, how many codes is it going to take to code something now, particularly if you have limitations in the number of codes that you can report, particularly on a paper form as opposed to the electronic form. Changes in some definitions or standardizing definitions where WHO didn't have definitions before. So standardizing, what does due to mean? What does associated with mean? So lots of things that we've already dealt with in ICD-10 CM. When they did their scan, they realized that other countries also were trying to do the same thing. Extensions. This is a list of all the different types of extensions that will exist, that do exist, not will, in ICD-11. So severity scaling, dimensions of injury, substances, histopathology, capacity. All of these are add-on codes. Again, everything is meant to be post-coordinated, not pre-coordinated. Information here on the coding scheme. And again, some understanding of why they chose the approach that they did. Talking about clustering and how you group like things together if they're related to one another. This may prove to be a challenge on the IT side because they're using, within the code string, they're using pipes, they're using slashes, they're using ampersands. That has some implications for the systems. So, implementation timeline. This is ICD-10 CM, and I see people smiling already. When we finally received both parts of the ICD-10, National Center for Health Statistics did an evaluation of ICD-10 compared to 9CM, which had been, again, continuously updated, to see if it was fit for purpose and ready to use, or was there going to be a need for a clinical modification. And so that work was done. Summary documents are still available. We don't take anything down unless we have to. So all of that history in terms of the evaluation is still available, but that took roughly 3 years. And then the National Committee held hearings between 1997 and 2003. We had our first NPRM in 2008, final rule 2009, another final rule in 2012, an interim final rule in 2014, and finally implementation in 2015. Needless to say, when creating this slide about possible implications for ICD-11, I stopped at the first line. And even on the first line, there are questions. For instance, when does this whole process begin? Do we wait until the World Health Assembly approves and adopts ICD-11 next year? No one seems to have the wherewithal to want to start now without knowing that the World Health Assembly is actually going, knowing that the approval comes next year. But, do we start then? Do we start a year later? WHO is daily, and I do mean daily, updating ICD-11. So do we wait for the first full update to ICD-11 to begin the evaluation? So there's some timing factors here. So everything else after that first line is a question mark. Because again, this is the beginning of the process. WHO may have completed the content of the classification, but the issue is what happens going forward. And each country will have to take that on board in terms of what they do, go through their regulatory authority and their regulatory process. And I'll stop there. We have 3 minutes. We can entertain questions, but again, if there is a groundswell of questions that are all very similar, we certainly can do a future presentation, and of course, send it to us in writing as well. But we wanted to give you, information now, such as we know it, but also to let people know that, the U.S., at least for the morbidity side of things, will not be implementing next year or possibly the year after. So there is time. I've had a lot of calls, as has, I'm sure, other professional organizations about what does this mean. This is the beginning of the process.
I've heard that learning new languages keeps your brain young, and so I think all of us are going to be young forever.
Thank you, Jean. Any other closing comments or questions before we break for lunch? Okay, thank you. We will reconvene at 1:30. Enjoy your lunch.